Jennifer and I were talking about advanced education or advanced trainings to do. We started talking about speech and language because it's an issue that really affects almost all of our kids with disabilities. It can affect kids with autism, kids with intellectual disabilities, kids with Down syndrome, learning disabilities, really everything. It's something that touches on a lot of our clients, and it's something that isn't always given as a service when it should be, especially with learning disabilities. I think is an area where we won't see it. We won't see that service, even though it is directly tied to reading, so that can, if they have a language deficit, for example, that can be something that can affect reading and academic skills. So we thought we'd bring in Julie Dems. And Julie Dems is a speech and language pathologist at IS Landing Pediatric Clinic in Bluebird Day School. And she was a witness at Verity and Rich's hearing and did such an excellent job. She was articulate and knowledgeable, and so we thought she would have a lot to share. She does speech and language, but she also does the augmentative communication devices, and really had a lot of knowledge in that area. And then to kind of couple with Julie is Mike O'Connor. I'm sure some of you have heard of him, but he's a parents attorney with Mock and O'Connor. And he's going to come and tell you some about advocacy tips, the law surrounding evaluations, IEEs, and I think he has a lot of knowledge to share. And I looked through his outline briefly, and it looks like something that a lot of us will be able to utilize in our practice. So please welcome Julie Dems.
Thanks, Julie. So I was just going to sit, so it's a little less formal, but if you guys have trouble hearing me or seeing me, I'm happy to stand up. So as Julie mentioned, I'm a speech therapist at IS Landing Pediatric Clinic, and within that clinic, we have a therapeutic preschool program. And so the majority of what I do is speech language evaluations and speech therapy services within that preschool age clientele in the school. So she mentioned that I testified recently on a case that LAF took, and I see a lot of times with my preschool clients, including the one involved in the case, that they come in with these IEPs from CPS that aren't necessarily consistent with what I feel is best practice. So I was very excited to come today and kind of share with you guys about speech language evaluations, identifying kiddos' diagnoses as well as the severity of those diagnoses, and then making recommendations for services and goals. So that's kind of what we're going to go over today. Really, what constitutes a comprehensive evaluation, and then how do we go from that evaluation to make recommendations for services. And then we'll also talk a little bit about augmentative and alternative communication. So it's very common to kind of deal with the top two, like Julie said, in almost every case that you're going to see. But I feel like the AAC part is what's really kind of missing or being underserved in the CPS setting. So first we'll identify what is a speech language impairment. So the Illinois State Board of Education says that a speech language impairment is a communication disorder such as stuttering, impaired articulation, language impairment, or a voice impairment that adversely affects a child's educational performance. So that last part is really critical. So when you're talking about giving a child a diagnosis within a school setting, we have to say that their speech or language impairment is directly impacting their academic performance. And that's where I think things are very different from private practice and within the school setting. So I'm going to kind of do my best to lay out the groundwork about what we do in the private practice, as well as what is kind of best practice based on ASHA and the Illinois State Board of Education. And then Mike's really going to tie it into the legal IEP aspect. So first of all, who is qualified to do a speech language evaluation? So most commonly, evaluations are done by speech language pathologists, which ASHA stands for the American Speech, Language, and Hearing Association. So that's the big governing body that oversees and certifies all speech therapists. So they must have a master's degree and then this certificate of clinical competence. So that means that they've completed this supervised postgraduate experience. So all speech therapists, after they've finished and received their master's or doctorate degree, they work in the field for 9 to 12 months, directly supervised by a certified speech therapist, and then they can earn their Cs and be independent with doing things like evaluations. So part of that is passing this national exam, all these professional development to maintain your certification and your license. And then not all states require a license. That will be shifting very soon, but Illinois has for a long time. So a state license in Illinois is also required. So I think that it's pretty uncommon. Yeah?
I'm sorry, quick question.
Mhm.
So let's say you doubt that somebody is qualified. Is there like a website or a place to go to?
Yeah.
Instead of just relying on their curriculum vitae, is there a place you could go to verify if they have these qualifications?
Yes. So if you have your certificate of clinical competence, you have all these extra letters after your name. So you have your MS or your MA, and then it's usually SLCCC, your certificate of clinical competence hyphen SLP. Did I write it by my name? Probably not. Oh, there it is. Look. CCC SLP. So if they have all those letters, then they have been certified by the National Certifying Organization, ASHA. They will also have an ASHA number. So for a lot of protocol for a lot of evaluations to list your ASHA number at the bottom, particularly during augmentative communications, which we'll talk about a little bit later. If you're going to submit that evaluation to get some sort of piece of equipment to an insurance company or something, they're going to make sure and double check using that number. So all certified speech therapists will have an ASHA number.
There's also on page 7 of my outline, there's a bunch of URLs, and there's one for educator licensure information, which tells you about whether staff have a Type 73 license from ISB, which includes speech language.
Yeah.
And then there's another URL for the state agency that licenses just about everybody.
Like the Department of Professional Regulation.
Yeah. And you can look up the person there too.
So you can look up and check if they have a state license to practice as well. Not every speech therapist is going to have that specific Type 73 if they're not within the school system. But yeah, good question. Please keep asking the questions and interrupting as we go. I know it's a small group, so I want to kind of keep a dialogue going if possible. So then other people that are allowed to do these evaluations are what's called a CFY, SLP, so they're within that 9 to 12 month period of post-graduation where they're still being directly supervised by a certified SLP. Same with the speech language pathology assistants. They typically have a bachelor's degree and then a variety of observation hours. So even though they're able to kind of technically sit there with the student and collect the information and complete the exam, the certified SLP will be signing off and is kind of liable and responsible for everything. So no speech language evaluation should be without a certified SLP's name. Does that make sense? Okay. Okay, so what is a comprehensive evaluation? So ASHA, we already mentioned, and then the World Health Organization kind of collaborate to dictate what constitutes an evaluation. So I wish that they kind of laid things out a little more specifically and said it takes X amount of assessments and this much information from a case history, but that's really up to clinical judgment, and that's why speech therapists went to school for a very long time to kind of make those determinations. So it's pretty standard like any other evaluation where you're kind of doing the record review, getting the case history information from the family, interviewing the teacher and the family, as well as the student if possible about what their particular areas of concern are, what the student's needs are, if there's any relevant diagnoses. You also want to know if they're getting any additional services. Do they currently have an IEP? And then what are they, what services are they getting in what issues are those services there to support. So that usually is a large chunk of time, especially in the school where you're kind of collaborating with the OT, the PT, the teacher, to really get a solid background on that child before you're going to start in on the evaluation process. So gathering all that information is really going to help you determine what assessments you need to administer for the child. So the assessments cover all the different specific areas in speech and language, and we will kind of go through those areas a little more in detail. Articulation, fluency, voice, for example. And then after you complete the assessments, you should be able to develop a diagnosis or determine that there is no significant concern or impairment. Following that, you'll make recommendations based on the frequency and the duration of the services. So, as I mentioned, talking about the specific areas assessed. So this is really after you've kind of collected all that background information, then you're interpreting that and saying, we want to look a little bit further into different areas. So, again, like I said, ASHA and the World Health Organization don't lay out, you must complete an oral mechanism, you must complete one language test. But what is best practice is having more than one, right? You can't just do one area of assessment, you need to include multiple areas. And we'll kind of do a couple little case studies to try to glean why you might do that. So the first area that's most commonly screened is an oral mechanism. So that's where we're really looking at your oral mechanisms for speech and feeding. So we're looking at kind of the face structure and function, the range of motion of your tongues, is everything symmetrical? And we're just seeing, is this client anatomically, physiologically ready for speech or feeding? And that's why I say that that's pretty standard, that it occurs on all evaluations, because that's what you see, right, when you come in, right? Is the child opening their mouth? Can they move their tongue around? Is there a syndrome or something, that a cleft palate that might be impacting their speech? So this is where you usually see your speech therapist with some gloves on and a little tongue depressor. Sometimes they have a little pen light, they have a mirror out, and they're making silly faces. That's all kind of to determine if the oral mech is ready for speech. Then we're looking at the actual speech. So we're looking at two things here. Can they make sounds? Can they output verbalizations? And then how intelligible or functional it is. So we're really mainly looking at speech sound articulations, that's the development and the use of sounds, and then that intelligibility usually relates more to the error patterns in their speech or the phonological processes that they use. I think I talk about that in more detail a little bit. So then the last area, language. And sometimes this can be very hard for people to just differentiate the difference between speech and language. I think you all know they're very different things. So language is talking about how we understand the words that we're hearing, as well as use words to communicate our wants and needs. The pragmatic piece is that social use of language. Do they maintain topics? Do they understand conversational turn-taking? Are they making eye contacts and picking up on gestures or other social cues? So that is a really important area, and there aren't a lot of formal assessments for that. So again, that's something that's more subjectively judged. But informal assessments are typically made every evaluation on language skills. Voice, so that's looking at the quality, the pitch, the loudness of someone's voice. Again, typically subjectively judged throughout every evaluation, unless the child isn't making sounds, and then you're making a statement right there about how they're not yet able to vocalize. Fluency, stuttering, or cluttering. Cluttering is similar to stuttering, but brings in kind of a language pragmatic component as well. There are formal assessments for that, and usually if that is an area that the team is concerned about, you're going to bring in a standardized assessment. And cognition. So in schools, this is typically assessed by the teacher or the school psychologist. I think Julie mentioned how a lot of times this is so wrapped up in language and they don't often get separated out. And so kiddos with learning disabilities don't receive the language services because they might not get the additional language testing, but there could definitely be a cognitive impairment as well as a language impairment. And so it's important to acknowledge their cognitive skills, get that background information from the team, and then do an additional language assessment to assess their language understanding and processing as well as their output. All right, so a little more detail. So we already said, so here I just wanted to kind of give you some examples. So when Julie asked me to come, she kind of asked for some specific assessments used and kind of what age groups you would use as assessments. There are thousands of assessments, and you can see all of these different areas. So there was no way for me to present on all of them, but these are the ones that I come across most common in my practice, as well as when I'm reviewing IEPs or reports from previous, from clients from previous places. So I just kind of wanted to blast out some names so that you might come across these in your cases, and then you kind of know what these assessments are looking at, as well as what types of disorders you might be able to glean from them, what type of impairment. So an oral speech mechanism screening. So I think I already mentioned that's the one where you've got your pen light out and you're looking inside their mouth, making silly faces in front of a mirror. It's for all ages, right? And all school age kids. And it's just a pass-fail screener. So typically if a child fails this test, for example, they're not able to move their tongue outside and back and forth, or they're not able to fill up their cheeks with air, or go pop, 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 then you're wondering, is there something anatomically or physiologically going on? And you're going to refer to a medical professional for that. Because additional testing might be done. There might be a neurological issue. Do they have a diagnosis that would relate to that? Is there a syndrome? And we always complete these if there is a feeding case, for sure. And especially in the schools, I think getting a medical team to look at that feeding case is really important. So if they're having issues with speech production that we think might be related to oral motor or physiological issues, we're going to look further at their speech production as well as their feeding, doing like a feeding observation. As I mentioned, refer to a neurologist. So another assessment in this area is the speech praxis test. So I don't know how many of you are familiar with childhood apraxia of speech. Okay, good. Who wants to tell us what it is? Yeah, Mike. Thanks.
Verbal apraxia has to do with difficulty in controlling the inner workings of your mouth to produce speech.
Yeah, so it's all about motor planning. So there's a disconnect between when the message is sent out from the brain with actually coordinating the motor movements to produce the speech. So we see apraxia very commonly in kiddos with autism, where there's a motor disconnect, there's a motor component, and so they're not able to kind of produce that speech on demand as easily. And so there is an official diagnosis in the speech world of childhood apraxia of speech, and that is a very difficult diagnosis to give. But what Mike said is this verbal apraxia or verbal dyspraxia, developmental dyspraxia, sometimes it's called, is given out a little more freely. And I think it has a lot to do with severity. So childhood apraxia of speech, they're very, very limited to no verbal output. Dyspraxia, you'll see a lot of groping, a lot of sound errors. I can never think of the character from the movie. All right, forget that. But they're trying to say mama, and it comes out ba ba every time. So they're so close, mama, ba ba, look so close, but they just can't coordinate that movement. But the more they practice and practice and practice, they're going to be able to develop that proper motor plan and make that more automatic. So developmental apraxia of speech is much more commonly kind of distributed diagnosis. Childhood apraxia of speech is more severe, takes more additional testing, and you just see it less often. So it's kind of a good thing to be aware of. So this is a good test. It's a norm reference test. It's really used for young kiddos. I like it. It's pretty easy to administer. And it's, you know, one where you're kind of flipping the book and they're trying to imitate the sounds and the words, and it's really working at that motor planning. And so with apraxia of speech, which is a little different than what we'll kind of talk about next, the error patterns aren't consistent. So if they try to say ma one time, they might say ba, they might say pa. They're trying and they're groping and they just can't master that motor plan accurately. Where if someone has trouble making the M sound, they're going to produce that most likely as the B sound every time because they're just can't make that M sound. So that kind of gets into the articulation, where those are just error patterns and sound errors. So they're just unable to make a particular sound production and they're substituting another sound instead. So the most common example probably is all the little kids that have trouble saying their O's and they can't say cow, car. They get stuck with that R, and it's a later developing sound. So you see in the schools lots of kiddos in for speech therapy with their S's and their R sounds. And kind of the major reason I think these services get approved in the school is because it impacts these kiddos when they're starting to read. And so that's, if we're looking for a red flag with articulation assessments, I think you're looking for it to impact their literacy and their reading skills. So the Goldman-Fristow is the most commonly used articulation assessment across the board. It works for, you know, all ages, and that's where you're going to diagnose those speech sound disorders or articulation disorders. It's a norm reference, standardized test. It gives you a standardized score. You can determine severity, make that diagnosis, and then it's pretty easy to plan therapy right from there. These two tests are actually related, so you can take the results from the Goldman-Fristow and plug them into this Conn-Lewis. And remember I mentioned before, this phonological phonology refers to error patterns. So you take all these errors that you heard in the Goldman-Fristow, you plug them into this Conn-Lewis, and it says, oh, they're backing. That means they can't make any sounds in the front of their mouth. Instead of saying dog, they're saying gog. And so you're thinking, oh, well, now I know the pattern. They're taking all those front sounds, moving them to the back. That's going to severely impact their intelligibility, which is going to impact their participation in school, their social relationships. So that is usually a pretty significant one. Those phonological processes are things that we develop to help us simplify speech. So from the very beginning, kiddos start cooing and gooing because they're laying on their back and their tongue is falling to the back, and so they're making all those back sounds, kuh, guh, guh. When they start sitting up, those sounds come to the front, and they're saying mama, da, da, all those sounds we make in the front. So an error pattern, well, backing is an atypical pattern because they should have made that switch, right? They should have, when they started sitting up and moving around, those sounds should have moved to the front. If they're stuck in the back, that is atypical and warrants therapy. And there's lots of information out there about phonological processes and when they typically kind of disappear or you age out of them. So this is one reason that this is a pretty easy area to get services warranted, because by age 5, 6, all phonological processes have disappeared. So if they have some of these lingering things, another one that's relatable is final consonant deletion. So kids speak in just these mama, da, da. There's no consonant at the end of their words for a long time. And some of our kids still speak like that up into preschool, and that requires intervention to help them graduate from that process.
Julie, the 2-21:11,
Mm-hmm.
that refers to age range?
Yeah, so 2 years to 21 years, 11 months.
Oh, I see.
Why it doesn't go to 22 years, I don't know. But it's the same age range for both of them. So it's all your school age kiddos.
Are there, like, so I work with a lot of English language learners,
Mm-hmm.
and so sometimes when they do these tests, are there Spanish equivalent tests that people do?
There are. I apologize for not kind of ascertaining which ones. For a lot of them, there are Spanish versions. I can't say, unfortunately, which ones.
Okay.
Yeah, that's a good question. Oh, I didn't repeat it. All right, just wanted to know about Spanish assessments, and there are a lot of Spanish assessments and assessments in other languages. I apologize for not highlighting that. Okay, so now we're looking at language. So what's the difference between speech and language?
Sound versus pragmatics.
Yeah, so it's just the actual productions of sounds versus how we use and understand all those sounds put together to make words, and then the pragmatic component as well. So a very common assessment used is the preschool language scale. So it's called the PLS, and everybody loves this test. They just came out with a new one. And this is really common for our preschool age kiddos. It does look a little bit at social language, and it looks a lot at auditory comprehension, so how we understand language, and then language expression. And it's looking at all those different language concepts. So are we understanding quantity and quality concepts? Are we able to use pronouns, use different verb forms? So it starts to kind of look at these meatier aspects of language rather than just kind of verbal output like we were looking at with the last one. So this particular one is designed for preschool age kiddos, so it just sort of goes up to 7 years, 11 months. And you're going to make a diagnosis here. It's a norm reference test, so you're able to get a standard score, plug that in, and determine severity, and then make a diagnosis about the speech language impairment. And we have to remember that within the schools, we're really looking at how this impairment impacts their educational performance. The clinical evaluation of language fundamentals is another really common one, the SELF. This because it caters to the older kids. So this test has somewhere near 10 subtests within it. So it's looking at very specific things in each of those subtests, such as memory, sentence recalling, reading comprehension, there's story and sentence writing, but there's a core part of the SELF that really just focuses in on that receptive and expressive language skills. So the reason I like this test, and I think a lot of people like it, is that it allows you to complete these little 4 quick subtests, determine a total language score, make a standard score, get your severity, and then administer some of these supplemental tests to really pick apart where their impairment could be coming from. So I really like it. And there's also really good literacy information for those. So for those kiddos that sound really good when you're talking to them, they have pretty good language understanding. And then the teacher says, but when they try to express themselves on the paper, just struggle to write these sentences or these coherent thoughts. So this is a good one for really picking apart that kind of higher level language stuff. So the functional communication profile is probably the opposite end of the spectrum, and I think that this one's used pretty frequently in CPS. So this is for our lower kids who don't have a lot of verbal output or functional use of language. And so what I really like about this test is it's not standardized, but it allows you to attach a severity to the results. So it's more of a checklist. But they have all the same areas that we see in the other assessments: language understanding, language expression. They incorporate sign language, use of gestures, or for our kiddos who are nonverbal. And they also really focus on the sensory motor component and a behavior component. So they have some checklists and allow you to really explore the whole child. So I see this used most often with kiddos who are on the autism spectrum, who have sensory processing disorders. It's more of a narrative. It really provides you with a lot of detailed information about how is that child communicating in his or her environment, and how functional is that communication. And it can be it's a really thoughtful assessment. I like it a lot. It's not norm reference, so it's not going to give you that standard score. The attachment of the severity, there's some guidance, but there's based on clinical judgment. But it really kind of puts together a nice report and a comprehensive view of all those child skills. We see that a lot, and I'm sure you guys see a lot, that you have kiddos that can't participate in a standardized assessment. They can't sit across from you at a table, which in order for the assessment administration to be standardized, usually requires for them to sit across from a table, for you to give them one prompt, or request them to do one thing. And we have a lot of kiddos that that's just not an option for them. And so in completing this profile, you're able to really use the team, collaborate with them to kind of describe the child's skills, and then determine their communication and language needs based on that. Does anybody have any questions? I feel like I'm going a little fast. You're good? Okay, so voice, we kind of mentioned, it's really subjectively judged. So you're going to listen for their voice quality. If the child's speaking too loud, if there's a hoarseness, if they're kind of hypo or hyper nasal, too little or too much nasal quality in their voice. And could that be indicative of some sort of laryngeal pathology? So in order to diagnose that, so a laryngeal pathology, sorry, interrupt if you don't know what that means. Could be something going on in the vocal folds. So I'm sure you've all heard of acid reflux. So chronic acid reflux can kind of wear away at the vocal folds and result in a really hoarse, kind of gravelly quality to the voice. We see this sometimes in our kiddos who are very young, who maybe are still not eating a lot of solid food, so thinking more of the severe, profound population. And then when they start vocalizing, we hear this gravelly, hoarse quality, and we think, well, what is going on? They might have had this reflux for so long, and we need to get another professional in here. So the ENT, or otolaryngologist, is kind of your go-to for that. So you usually start with the pediatrician, you need to get a referral there. But the ENT will do a scope. So they have a couple different ways to scope and to take a look and see if there is some sort of pathology. Is there some damage to the vocal folds as a result of reflux? Is there a nodule or kind of like a little cyst or a bump on the vocal folds? Because that child is yelling all the time, and that might be impacting them, and now they have to use so much more force because there's a little bump getting in the way of their vocal folds moving smoothly. So if there's something atypical with the voice quality, you're usually referring to somebody else, unless the speech therapist has access to the scope, but that's not very common within the schools or most private practices. So fluencies, I think I mentioned, the stuttering severity instrument is a norm reference standardized test that really lets you look at the frequency of disfluencies, the additional secondary behaviors that commonly occur in response to stuttering, such as kind of hand movements or eye closure, and it kind of incorporates all of those secondary behaviors as well as the frequency of the stuttering pattern to put together a severity rating. So that's commonly used in the school, that severity instrument. So this one just only goes up to 10 years of age. There are a couple more out there that go up a little higher. I think that's not a challenging one to get services warranted for. So, thanks, Mike. Mike helped me find this tool. I was looking for a good one. I really like this bar graph. So we kind of talked about all of these assessments and how you can create a diagnosis and create severity or determine severity. And Mike shared with me that this might be kind of a new visual for some of you guys on how to kind of determine severity from a standardized score. So you can see kind of this large middle blue section is your average range. So if students receive a standard score on an assessment between 85 and 115, that is within normal limits, no services are warranted, no diagnosis is given typically. Our students that start to fall kind of on this side of the curve come into the moderate, mild, moderate, and severe range. So I know you guys have this in your packet, so I'll just kind of move on and we can talk a little bit more about how you determine severity. So as we said, a standard score from the assessment between 85 and 115 is within normal limits. There are certain cases where you can get services awarded. So let's say that a child has a score of 87, but they are experiencing extreme frustration in the classroom. They are unable to make progress in developing reading skills. So say they've got this test on a speech assessment. So they have a variety of different articulation errors, but they're still kind of within normal limits. But it's impacting them socially, it's impacting their ability to participate and to develop their academic skills. You have to use your clinical judgment and say, even though technically this would be, a mild to within normal impairment, it has all of these negative consequences that are above and beyond typical. So it happens occasionally, but that's why it's just so important to really look at academic performance, because it looks so clean cut up here, 85 normal, 84 not, but that's not always the case. And there are a variety of things impacting that standard score, right? Like a child's age. Well, if they are about to have a birthday in 2 months and switch into this next age category, they might get an extremely lower score in a few months. So you got to kind of consider all of those different factors. So standard deviations. So you guys kind of have your graph in front of you. If you're looking at kind of 1 to 1.5 standard deviations below the mean, the average of 100, we're looking at a mild impairment. So this is all based on the Illinois State Board of Education's kind of criteria. So they define that as a mild impairment. Just kind of below that, 1.5 to 2.5 standard deviations would be a more moderate impairment, and then greater than 2.5 is severe to profound. Yeah.
So, I'm sorry, this question is so basic.
No, please ask.
But you talked about all these different evaluations, and now you're talking about the score of 85 to 115. And what I don't understand is, are you saying that every single evaluation that we talked about ends up with a score on a scale of like 0 to 160, and then you average it? Like, how are you coming up with this, this determinate score? Okay, so the question is, where do we get these scores from? So we get these scores from these different assessments, and how do we all of a sudden then plug them in to get severity? So not every assessment produces a standard score. So if it says norm referenced up here, that means it's a standardized assessment. That means that the test has been given to other kiddos within a similar age, and they've used all of those scores to create this bell curve. And so the standard score only comes from standardized assessments or norm referenced assessments. So if you give a child an articulation assessment, the Goldman-Fristow, and they are 3 years old, and we'll kind of go through this, and I can't remember off the top of my head, they get 45 errors on the test. You kind of plug that into the manual and you say 45 errors, the manual says translates to, for this child in this age, a standard score of 72. So the manual helps you kind of calculate the child's performance on the assessment. And I know, Mike, you look like you want to jump in here.
No, I mean, you get from raw score to standard score.
Yeah.
And I mean, I'm just thinking about all the ways that goes wrong.
Yeah.
I mean, just simple errors.
Absolutely.
Writing it down one place and then wrong way another place, or even just not adding the numbers right.
Mm-hmm.
These things can happen.
Yes.
Well, I guess what my question also is, I mean, I get it if it's a standardized test. If it's a standardized test, it's going to have a scoring system or a norming system.
but you talked about tests that aren't standardized or don't have this, and so I guess my question is, doesn't that make this end number very subjective? Or is there some objective way that speech pathologists are taking these non-standard scores and creating numbers out of them?
Well, if the test is not standardized, usually a speech pathologist is not attaching a standard score. They are going to attach a severity, which is completely subjective. It's completely subjective. It's just based on the child's performance in that assessment. So the one that I mentioned that is commonly used that is not standardized is that functional communication profile. It is essentially a checklist and a description of the child's current skills. And based on how you kind of complete that checklist, it allows you and kind of encourages you to attach a severity to all the different ratings. That is clinical judgment. That is what all those C's are for. It's based on kind of your expertise and all the information that you gathered from that child. What is the severity that you're attaching? That's where it gets really messy, right? So if there isn't a standard score and you can't plug in this nice little into this graph and determine following kind of Izzy's criteria saying, well, they're this far away from the mean, we're going to say they're profound. It's all about clinical judgment at that point.
So I'm wondering, like, when you have multiple tests that you're giving, like a standardized for the articulation, and then language, and say they get, mild severity on both with their standardized scores. And then, I mean, in best practice, are the speech pathologists saying, okay, 15 minutes for the articulation, and then 15 for, the language issue?
Yeah, absolutely. So if they have those dual diagnosis like that, then their specific IEP goals must address both of those areas of need. And so then their services would, right? So if they are getting 30 minutes a week and they have a speech articulation disorder and a language impairment, that 30 minutes must cover both goals in both areas.
Sorry, another question. So a lot of our students have really low cognition, and how then? Because I'll have a kid maybe that will just have really bad articulation. They could take the Goldman Frisco, but then they still won't get services for that area. Is cognition really is it gonna affect where they couldn't work on that? Is there any areas that where their cognitive level is so low that they couldn't, services wouldn't matter, or?
So the question is, are there any areas where if the cognition is so low, services wouldn't matter? That's really a tricky question to answer because that's definitely going to be case by case. Because low cognition is just a hard term to tackle. So low cognition for a 15-year-old versus low cognition for a 4-year-old is very different. So it's hard to say. Would articulation be the priority for that kiddo maybe if they have other cognitive goals and language impairments? Probably not.
But also language impairments can suppress your scores on cognitive tests
Yes.
as well.
Absolutely.
So it's a tricky cycle there.
Yeah, so that's what I mentioned. You have to make sure that you're getting a comprehensive look at both language and cognition. Yeah.
So would you say that anyone who falls in the 1 to 1.5 with a mild impairment that should be receiving at least some?
Yeah, and we'll talk about that. So what kind of coming up in the next slides, what the Board of Ed says about the minutes of service recommended for each of these severities.
Well, I found in different schools in our district, and I'll even my own son. 1 month we moved schools in the district. 1 month he did not need any speech and language services. The next month when we moved, I told them I was going to be seeking an IE that they paid for, and the speech and language tested him, and all of a sudden, boom, he had all these issues which I knew he had. So I'm wondering how much is for a child, a grade school child, how much is that, like you said, 45 errors? It seems like, and I've seen this between schools in our district when other children have moved, it seems like I can tell you whether they're going to get services based on whether the speech and language pathologist who has done the testing. what are they doing on these tests? How is there so much room for deviation? I guess is what the question, do you
Yeah.
understand my question?
Yeah, I think I do. How is there so
Yeah, I'm
much
not sure
room for
what they're
variation?
doing with these children, but like I said, I can kind of say, oh, they didn't get it and they probably need it because this
Yeah.
person did it.
So that sounds like that's based on the therapist, and that maybe that.
Well, what do
each
they do
therapist
on
is
these
kind of following
tests?
a
For
different
example, like a
protocol.
receptive expressive language or an auditory processing. Is that something that leaves a lot of discretion to the person doing the testing?
Not typically, and especially not if they're standardized assessments. They're, just as there's a standardized way of administering the test, so
Mhm.
they limit the number of repetitions or the amount of kind of tactile or visual prompting you can give, they say, unless it's this answer, incorrect. So there's a standardized way of recording those assessments so that this score is accurate. So if you're kind of violating that standardized and that norm way of administering the test, then that standard score is not going to be accurate. So so to answer your question, there shouldn't be variation. If the two different speech therapists evaluate the same kiddo, they should have the same results and the same recommendations, particularly if they're using a standardized assessment. Of course, there's going to be a slight variation maybe in their kind of interpretation of those results or their goal writing, but that standard score should be the standard score.
Fairly consistent.
Yeah. I mean, there's always kind of a confidence interval saying there's just like a little bit of allowance for that kind of administrator differential, but maybe off by a slight margin, not either qualifying or not qualifying.
Well, then what happens with the children with specific learning disabilities like a dyslexia, where you often do find, well, like you said, and Julie said at the beginning, how are they missing these issues, or how are they not getting services? It's just they're not being tested?
That's a good question.
Oh.
It could be, yeah, I think that's why we're all here, right? 'Cause
Yeah.
that happens
Because
all the time.
And it's usually with my son has the, dyslexia, specific learning, and that's where I'm seeing it the most is with the SLD kid.
Yeah. So, and I think it probably varies school district to school district, which I think you're seeing.
Yeah.
And that if that, particular area of need or service is being provided by the teacher, then maybe the school district might, and I'm, kind of hypothesizing here, determine it redundant for the speech therapist to also address that same goal. I wish I could answer that
Okay.
question.
No, that's
Because
good.
it is something that a speech therapist should be assessing. Yeah.
Thank you.
Yeah. Yes.
To that end, are there indicators for us to look for in a report that we should seek a second opinion? So like obviously if there's a situation where a kid is presenting with something and we don't think that the language or the diagnosis or the evaluation matches up, but we have several situations where things like that happen and
Yeah.
we're
Yes.
lowly attorneys.
Thank you.
So what are good indicators or ways we might be able to convince a school district if they've already paid or they've already
Yeah.
sought out this evaluation?
So when to seek a second opinion
Or even an
a second
independent on your own,
evaluation.
maybe.
Yeah.
Or
Well,
what
so I
to
think
look for
that's
in choosing our own evaluators or any of that.
That's
Right.
That's good, yeah.
So I think we're looking at how comprehensive the evaluation is, right? So if the example of a child who has dyslexia is sent to the speech therapist for an evaluation and they just administer an articulation assessment, well, that's a red flag, right? Because we think, well, that's about speech production and we're thinking about kind of more language literacy and processing. So does the speech evaluation truly assess this area of need? And then you can look at the standardized assessment. Did they do a standardized assessment or a comprehensive assessment, or did they just make observations, take some case history, and talk to the teacher? And I think, that's why I really stress the importance of getting that case history and that record review, because when you look at a speech therapist evaluation, if it is not matching kind of the concerns of the teacher's report and the occupational therapist report, that's a red flag too. So the OT says they cannot follow a direction
to participate in occupational therapy. They struggle with imitating, these movements or these words during our exercises, and then the speech therapist or the teacher says something completely different. Well, that inconsistency right there, I think, is a red flag. I know I'm going to follow up, so you look like you're deep in thought.
So the matrix itself doesn't purport to tell us why these numbers of minutes make sense. Has ISB someplace else put out some explanation of why they think research?
And it's in the reference. I apologize for not making copies. But so ISB has this, it's in the references, it's this, looking for the name, that matrix, right? The severity rating unit matrix, and they have that posted that kind of translates all of this severity rating into minutes of service.
But do they, at some other place, because it's not in that document, say why they are allotting these number of minutes? Like, what's the research that shows that if you have a moderate impairment, you should get this number of minutes? Or
Yeah, that's not
just
justified.
on high.
It's really related to, I think, the child's individual, the impact on their ability to communicate or respond in the school environment. So why they said, mild minimally affects. So I think it's just related to that bell curve, as they see that number of population minimally affected, and then that would warrant that lower number of services.
So
you
let's
have
say that they are getting
matrix.
speech therapy outside of school an hour a week, and then, they have a mild impairment, so the parents are saying they should have, 15 to 30 minutes, and, this is just school-based, not saying like overall, like outside therapy, so they can't say, well, you're getting 60 minutes outside of school, so you don't really need it inside of school.
No, this is what the state says in the school. This is based on, what's recommended for the school to provide, right? Because I think.
But for you, that chart would be a guide, would it not? And you would look at all the information and develop the recommendation what you thought was reasonable in terms of speech language services.
Yes, exactly. So you're taking in consideration all the different services. I think the school's obligation to provide those services comes first. So I think what you're saying, Mike, is that if a kiddo comes in and the parent says, they're getting 30 minutes a week at school, but we want some additional help. And I say, well, it's really, more of a mild delay, 30 minutes a week should suffice. That would be appropriate versus me saying, they're only providing 30, well, it's a mild delay, but we'll do 90 additional minutes. That's not ethical, right? So this is a guide for private clinicians as well.
But you might say that the kid has a mild impairment, and you might only say 15 to 30 minutes. But because of some other things that are going on, you might say, well, 30 to 45 would be more appropriate.
So like if a child has dyslexia, for instance, you may, even if it tests mild, you may end up giving more minutes because you know that that's impacting that too.
Absolutely.
Okay.
Absolutely.
Thank you.
Yeah.
And the matrix says minimum of these ranges.
Yes.
It's not, for instance, a maximum. So when they say this is what the chart says, it says minimum of that. But
Right.
You didn't talk about language samples and analyzing mean length of utterance and stuff like that.
Yeah,
Can you comment on that?
Yeah, I can, because that's a little more, so there are a variety of different assessments to kind of help standardize that. But that gets to be a little bit more subjective. And so with some of these assessments, there are formulas within the assessment, so the preschool language sample, for example, to take a language sample from the child just in conversational speech, and then you check off things on this checklist. Are they using pronouns? Are they using a variety of different verbs? What is their mean length of utterance? How many words in a sentence are they commonly using? And that checklist is not always attached, or the results of that checklist is not always attached to the standard score, if that makes sense. But that is an area that you would comment on in your report, and that would lend to the diagnosis and the severity. So go ahead.
So if this is separate from that last question, but if you're, recommending minutes and then you're seeing a student for a while, but they're, maybe they have more cognitive issues or things like that that are preventing them from making progress in this, and, you know, the speech therapist says, well, they're not making progress in speech therapy, we're gonna dismiss them from these services. Is that something that would be appropriate to do? If
That's a tricky question. So
when
when
you mean like
is
case by
it-
case, then is what you're
Yeah,
saying.
so it's case by case, but, so I think there's also a time frame to look at as well. So if you do an evaluation and it's less than a year, still within that IEP year, dismissing them for services does not seem appropriate. So you have recommended services, you've created goals that should be achievable within that IEP year. You can't just give up halfway and say we're gonna dismiss because they're not making forward progress. You can adjust your goal, but they've just been evaluated, and typically the results of that evaluation are good. Well, to determine eligibility are good for multiple years, but to recommend specific services and develop goals are good for that entire year.
Yeah,
So-
but let's say it's been, you know, multiple years, and the student maybe has now developed more behavioral problems because they're getting older and more frustrated and things like that, and so they're maybe not presenting, you know, the ability to sit across the table from you during speech therapy.
Yeah, I think this is a common misconception that speech therapy must happen at a table. I hear this argument a lot. I'm not trying to pick on that example.
You said that was the evaluation. Was
But
you said
yeah,
across the
no,
table.
I think that is an argument that school speech therapists use a lot, is they just can't participate in speech therapy. And speech therapy can happen anywhere. So I would really look at reevaluating the goal. If the child's not meeting the same goal after 3 years, well then that goal isn't appropriate.
I agree with you 100%.
Yeah, no, I know we're on the.
I'm just saying, I have, you know,
So that
I look
would
at
be
these
my
records
argument.
and I say, this person can't participate in speech therapy, so we dismiss them from
So-
it.
Yeah, I mean, I would say that is,
Well,
in
part
my
of it
opinion.
maybe
that
you
is
need to
appropriate.
reevaluate the provider, because.
That's what I was
provider
thinking.
Provider has an obligation to engage the kid, and some kids can be challenging.
Yeah.
And if the provider is not able to engage the kid, then he needs to step back and determine what do we need to do differently.
Yeah, and typically within the goal, they're gonna kind of set up that condition, right? So the goal might say, you know, during a seated tabletop task, well, if that child can't participate in a seated tabletop task, then it's gonna be while we're, you know, pushing a ball on the floor, or he's, you know, in a swing, or during his, you know, preferred activity, the speech therapist can come in and participate. So I think, I agree, the speech therapist needs to get a little more creative and cater that goal to the child's needs. I think that happens, it's just very unfortunate, and that's part of, I think in my work I see that very frequently. Parents go to CPS, get an evaluation in an IEP, have some recommendations, and they just are shocked at the types and amount of services that they've been awarded in comparison with what their child had been receiving. So their child was receiving speech therapy 60 minutes a day for 3 days a week. And then they go into the school and they say, well, we're just going to target this one thing for 30 minutes. And then years down the road, are they going to get dismissed because this one particular goal they weren't making progress in? That's a shame. It makes me very sad to hear that.
I had made progress and there was an error and they didn't have speech therapy for the last IEP year because it was a mistake, and they're like, oh, we need to put back in speech therapy. And then they're like, well, they're making progress without it, so they don't need it anymore. I'm like, what are you talking about?
But what progress could they have been making?
They're not making speech. I mean,
Yeah.
the student is deaf, and so I feel like the student needs a lot of, you know, he's been making progress because he's finally at a school that can teach him appropriately.
He could have made more progress if he had the
Exactly.
appropriate.
It still frustrates me to say, like.
Yeah, and I think that, you know, we all can name these, yes.
So I want to say we have a lot more of the presentation.
I
to do,
know,
So
I know.
I'm going to take more
you know,
questions.
these conversations are so good.
I know.
Can I ask a quickie? Is there anything for consult? That's all I want to know.
No, it's fine.
Yeah.
Does consult minutes line up with service delivery?
Yeah, so that is I'm glad you asked that. I'm kind of anticipating that question.
Sorry,
I
I
Mike
thought,
could help me answer.
I thought you'd say no and then move on.
No, and maybe Mike will touch on this later. But the consult minutes, oftentimes I think they kind of get used in these situations where it's
Yeah.
like, oh, they're making progress in this, you know, as a way of kind of weaning off the services or helping support the generalization of those services and practices into that special ed classroom or that educational setting. So that's where we kind of reflect back on this goal and this impairment must impact the child's educational performance. So I feel like that consult time is really designed to kind of help generalize and supplement those services, because the speech therapist can't be with the child all day, every day. And the rest of the team needs to know how to kind of implement and support. Does that make sense?
Yeah.
So there isn't as strict of a formula for that. Okay, thanks, Julie. Sorry.
No, you're
Digress. So, okay, so this matrix. So I apologize that we don't have copies. Julie, would you be able to make copies of this matrix?
Yeah.
Like on the break or something for everybody to have? Unless it was in your handouts, Mike.
Well, I have got, is this what you're talking about?
Yeah.
Yeah, I didn't include it.
Okay. It sounds like you guys would really like to have that. It's a very helpful document. So, you know, we kind of talked about this a little bit, how we determine what the severity is, and then what does ISBE say that severity then translates into for minutes per week. So I read through this document very closely and was feeling a little kind of up in arms, which is what I think we're all kind of feeling when we were having these heated conversations, because I think it's very rare to see these higher level number of minutes on an IEP document. But this, like I said, came from the Illinois State Board of Education. So it's all about how the severity, how it directly impacts the child's communication and participation. So developing goals from all of this. So there are lots of people that, you know, created these little formulas for writing goals, and you put this part of the goal first and last, and I think every kind of school district and therapist or teacher has their own kind of preferences, but as long as it includes these things, it should be a measurable and sufficient goal. So identify the desired skill or behavior. So can anybody give me an example, like maybe in your case, of what would be a desired skill from that client? What would maybe the speech therapist be looking for?
The deaf client?
Yeah. So what are they looking for?
I mean, I think him participating in conversations and learning new signs.
Yeah, so maybe learning a new sign. So that would be your skill that you'd want to see. So the child will learn one new sign, and then what's their level of support that they would need to complete that? Are they going to need physical prompts or tactile cues? Will they need a specific model? Just the verbal prompts, you need to sign help or you need to ask for help. And then how is that measurable? So what's the specific criteria? So in 2 out of 10 opportunities, they'll produce that sign or that skill, 50% of the time. And then what's your condition or location? So some people will indicate within the classroom setting, or at during a seated tabletop activity, within structured conversation, something like that, your specific condition. And then you always have to make sure that this goal is attainable within 1 IEP year. So we are aiming for all of these kiddos to meet these goals. So I think that that is something to kind of look at as well, is are these goals being written so that the child has the potential to meet them in the year? That's the design, that you revisit and rewrite these goals every year. So making sure that the goal is attainable. And so within the IEPs, they must be linked to what used to be known as the Common Core Standards, now the new Illinois Learning Standards. And so that, I think this can always be really tricky, because you have to take a Common Core standard from their age level, right? And so that might be really, really far away from what the child's skills are. And so I've seen a lot of creative ways that these Common Core, the Common Cores are kind of whittled down and tweaked to fit the child's needs and the child's goals. And I wish there was a better formula for that, because that seems like there's a lot of room for interpretation with that particular process. Yeah, it's kind of unfortunate that there's not a different way of doing that. But right now, instead of kind of applying a first grade level Common Core that might be more appropriate for your 6th grader, you need to go to that 6th grade standard and then develop a goal that's appropriate for your kiddo. Somehow fits within that standard. I know you're shaking your head, Julie. But
Oh, it's just a challenge with every single goal. Try to make something that's actually useful for our kids that are maybe at the first grade level, like you said, but they're actually quite older. So.
And really understand that interpretation and how they kind of fit and relate back to the Common Core.
And the other challenge is that have it be objective, so that there's some specific level of skill that you're expecting to attain that's objectively measurable.
Yeah.
And is linked in a way to the present plot, the present levels of performance. So you can say that in 1 year, we're gonna have this much improvement in the skill, and it's objective, because the Common Core tend to be a bit vague.
Yes. Yes.
And if you have a vague goal, then you have trouble challenging whether or not students made reasonable progress.
Yeah, so I think you're right. You're creating these very specific goals for the areas and the skills that you're trying to target, but linking them to these vague, kind of unrelated Common Cores. Did you have a question?
Yeah, I guess it's a comment. I mean, I know that your learn a sign in a year that probably wouldn't be your goal, right? But
for some kids it may.
It might, right? But for somebody who's just deaf and is now finally in a decent school, that wouldn't be the goal, right? And I guess, I mean, it seems to me that with a lot of kids, speech language buying into these notions of how much kids can learn just makes it kind of irrelevant. I mean, like with kids with autism, I see them often learning to talk through intensive ABA. I see them almost never learning to talk through speech therapy that targets one little thing a year. I see kids learning sometimes when they get something like language for learning curriculum that targets like 400 things a year that really I mean, that's the kind of thing it takes to get kids up to Common Core state standards.
Yeah.
And I mean, I think that just buying into this, well, we have to set goals that are attainable. I mean, we have to set goals that would mean something. And I think often that means doing a full curriculum and not something that's going to be done 30 minutes or 90 minutes or over 90 minutes were that ever to happen in speech therapy.
Yeah.
And I think there's an inherent bias against setting those kinds of goals for fear of saying, well, we didn't meet the goal. You know, we were afraid of setting it too high. So, well, to be safe, so we don't get caught not meeting the goal, we'll set it lower. And that just, you know, impedes the potential for progress, I think.
Yeah, absolutely. I mean, I think that, you know, when we're kind of creating a goal we want to be attainable within the year, we have to also think about the frequency of service that the child's getting to target that goal, right? So learning 1 sign a year might seem like a very small goal and they should achieve that in a few months. But if they're getting 15 minutes of service or 30 minutes of service a week,
But goals are supposed to drive services, and I think we need to stick up for meeting the goals, and
then
services need to match them, not come from the interest.
Absolutely, absolutely. I think that's where that kind of sticky web comes in of what's driving what.
Mm-hmm.
Yeah. Okay. So I have a couple little case studies, and I knew that you guys kind of had your own case studies, so if we'd rather kind of talk about some of your kiddos, I'd be happy to do that. These are just...
Well, why don't you start with yours and then if people can follow up.
Okay, perfect. So this is a kiddo who's in a regular ed kindergarten classroom. She has an IEP for some OT services because she's got a lot of frustration. She has ADHD, and she's got a couple little small behavior issues, so around that kind of decreased participation. So she was recently referred for a speech language evaluation because her teacher said she's just using baby talk all the time, nobody can understand her, and they're really concerned about the SR and the TH sounds. So and I know you guys all have the answers, but what is the speech language pathologist going to test? What areas are they going to make sure to focus on? So we're concerned about her intelligibility, her SR, and TH sounds? Are we gonna look at stuttering? I think this is where those kind of like, I think you were asking before about like, how do we know if it's an accurate or a comprehensive evaluation? It's all about the assessments matching the concerns. So we would give her an articulation test, and we would look at the oral mech and assess that area. We would make sure that we did a standardized assessment in articulation if possible. With this kiddo, do you think a standardized assessment is possible? Regular ed, kindergartner? Yeah.
Yeah, the Goldman Bristow.
Mm-hmm. Yeah. Yeah, we can give her a standardized assessment, we'll give her the Goldman Bristow, we'll get a standard score from that. So you mentioned a language sample, so we're also going to screen her language skills, take an informal sample, make sure that that's not an area that we need to follow up. Just because the teacher didn't mention language, we definitely want to screen and make sure that that's going well. If she's having a lot of behaviors and frustration, we want to look at pragmatics. Is there something going on with pragmatics that maybe hasn't been noticed? That's kind of helping with those frustration and that behavior issues. And then oral motor, right? So we gave her the oral motor, she passed, her language was typical, there was no pragmatic issues, and she got a standard score of a 71 on the articulation assessment. So are we giving her a diagnosis, and what severity could we attach?
Let's give her a diagnosis.
Yeah. Yeah, so a 71, so that's not the 85 to 115.
Right.
So a diagnosis, so I think some of us think like a big medical diagnosis, but a speech language pathology diagnosis could be a speech impairment, a speech sound disorder, we would say. So she's having trouble with her S's, her R's, and her THs to the degree that they're impacting her intelligibility, and she's lisping. And so that's not just a normal R error that might be kind of typical for a 5, almost 6-year-old. It's pretty severe frontal lisp when she's having a hard time being understood. So she got a 71, she has a speech sound disorder or an articulation disorder, and what's the severity if it's a 71?
It's almost 2 standard deviations, right? So that was moderate.
Yay. She has a
Why not do
moderate-
receptive language testing to see whether maybe she's frustrated because she doesn't know what's going on too, especially since she's not expressing herself very clearly, so it's hard to tell what she's saying. We don't know why she's not participating. I mean, it just seems as long as you're doing a test, why not do a full battery?
Why not?
And why not say CPS should do a full battery instead of this area of suspected disability and relying only on what the teacher tells you about?
Right, so if she's not having trouble responding and following directions and answering questions in class, and the teacher does suspect, I mean, I imagine the teacher would report that too if she had some suspicions, but you're going to kind of glean some of that from your language sample when you're asking her questions. Usually during a language sample, you ask a couple questions, ask for clarification, see if they're able to kind of problem solve to explain something differently, give a couple directions for them to follow, and if there are any concerns at all during that language sample or that informal conversation, then you're going to follow up with a formalized test. Yeah, absolutely. It's a good question. So, okay, so she has so let's say language, everything was typical, all this frustration is just related to kind of her, her ADHD diagnosis or OT needs, there's a sensory component, and then just her limited speech intelligibility. So she's eligible for services, and she's getting, according to that matrix, 60 minutes per week. So I can't speak to how this would directly translate to an example within CPS. I just don't see a lot of articulation cases for a 5.5-year-old getting 60 minutes per week of service.
Their approach is, I think, the killer grow out of it.
Yeah, yeah. So, that, you know, what the research says about articulation therapy right now, and that's kind of why I use this example, because I think it's maybe boring and you guys don't have a lot of cases about speech sound disorders, but they say that the child should get more frequent services, these short little bursts. And so in some school districts, they're practicing this, and then speech therapists are popping in for 5-10 minutes every day, because it's that frequency and that repetition is what builds up those motor plans and that motor memory and helps them grow out of it, right? And that you're supposed to target these sounds when they're emerging, not when you should have mastered them. So R is always the example. We all know an adult who this day still has trouble with their R's. So for a very long time, and still a little bit today, children weren't even qualifying for services to help with productions of R until 3rd grade. So that is so many years of doing the wrong thing and having to unlearn that habit and that motor plan. And what the research is showing us now is that we need to target these sounds and these errors when the sound should be emerging. So at around 4 years old, that sound should be emerging. So what that means is that it'll show up in some words, or maybe always at the end of word or in the beginning of words. And the R is the trickiest sound because there are so many different versions of R, ear, ire, so the kids might have it when it's attached to an E, and they might show up every once in a while in the beginning of a word. So that's when you should target, because they have that plan somewhere, and we want to hone in on that and not have them learn the wrong way to do it. So I think this would be a very unique case if this actually translated to an IEP. So this is a client that I see in private practice. I feel like this is absolutely best practice, ethical, within what her rights are, and my rights are as a therapist. I just wouldn't anticipate that this would translate to an IEP. I think the one thing that she could have going for her to get an IEP, and this is a conversation I've been having with her mom when she goes into kindergarten, or well, she's not quite in kindergarten yet, so when she goes into kindergarten, is she going to get an IEP? Will the OT qualify her for IEP? Will the speech therapist at school qualify her for OT, or for speech services? Mike's shaking his head, probably not.
But you're describing it 60 minutes a week. You're doing that now in the clinical practice?
Yeah, and she's making remarkable progress.
But you're also saying that as a member of an IEP team, you would recommend 60 minutes a week in school?
Yeah, to continue that progress. Yeah, and ensure that she develops those skills. And I think it's just it's that tricky about what is best practice. Because best practice versus sufficient services to access their curriculum.
Well, my part will talk a little bit about the legal parameters and free and appropriate education and things like that.
Okay. All right, we'll keep moving. Okay, so based on her results and kind of that ISB matrix, this would be her severity and the service recommendation. So writing some goals for Annie. So why don't you guys just kind of take a minute to read through these, and then we can kind of talk about what you like or don't like about the goals, which one is good, which one's not.
I would ask you if you could clarify what you mean by minimal cueing.
Yeah.
Because something that I see is that the cueing process gets distorted, and intensive cueing is sometimes used to build up the kids' reported capacity.
So within, and I think you're going to go through this, how you write benchmark goals from all of these. So you're going to define that a little bit further in the benchmark, right? So they're going to start with max cueing, which means maybe your hands on their mouth, giving them sort of tactile prompt, and then moderate cueing would be this. And so should there be a definition in there? Minimal cueing means, slight visual prompt.
Just pointing.
Yeah. Yeah, absolutely. Okay. I think we see that a lot too. So, so let's start with the first one. So during this IEP year, Annie will produce
Z in the initial position of words using placement strategies with 90% accuracy and minimal cueing. So let's say we defined that as one tactile prompt during structured activities. So we have, this has to be in all goals, right? That we're going to do it within one IEP year. Are we targeting an appropriate skill for Annie? She can't make her Z sound. We're targeting Z. That seems pretty good. We talk about kind of the condition in the prompting. We wanted to do it in initial position. We're going to use these placement strategies. So sometimes that's kind of like a visual or a tactile prompt. And then minimal cueing, we're going to do that and a minimal cue. And during a structured activity, so not kind of in conversation while she's running around the room. So what do you guys like or dislike about that goal? We got all the requirements, right?
Well, based on what you said, it sounds like you should be targeting the emerging, ones are supposed to be emerging too, like R, and not let her keep doing R's wrong.
Yeah.
For the next year, and I guess so, target them all and teach her parents and teachers to follow what it may be doing.
Yeah, so it'd be an
Possible.
additional goal for sure of sharing strategies with the family.
Yeah.
So if we're working on just Z in the initial position of words, just saying how many functional words is she going to be able to say? Zip, zipper, zoo. We want her to do more than that in 1 year, right? So I think that's kind of the red flag for that goal, is that she should be able to achieve that in far quicker. So then looking at the second one, so this would just be one goal for her. So I like what you said about kind of having a goal to target more sounds. So maybe in addition, we would have one for R or for TH, some of these other kind of problem areas for her. Typically there's more than one goal written. So are there any kind of red flags in the second example? So here it's got a couple sounds.
Well, instructional year.
Yeah, so that's good. So that's another word for kind of IEP year. So we have this one instructional year, her IEP legal year. She'll be able to produce, so at least now we have two sounds. So S and Z are often paired because they're made in the exact same place in the same way. One has a voice and one doesn't. And we want all positions of words in spontaneous speech. So if we're going to target these two sounds every day or every week for 15, 20, 30 minutes, depending on how many goals we have written, we should be able to in a year get this going in her spontaneous speech, right? So that seems pretty good with 90% accuracy and minimal cueing. So maybe one prompt, and we would have to define what that was, whether it was a tactile cue, a verbal, or a visual prompt. So that one doesn't look too bad as one of her IEP goals.
I always have trouble figuring out how the provider determines 90% accuracy versus 80% accuracy.
Yeah,
It's sort of
well, that's part of the whole data collection process,
Yeah.
right? So, sitting with the pen and tallying, yep.
Can you put that in a
and-
folder to keep track?
Yeah, do we?
We're supposed to.
Yeah.
We're supposed to be able to,
So
I ask
within-
for it a lot of times.
So, yeah, and so within this, so this will be our annual goal, right? And so then this will be broken down into these different benchmark goals that have maybe more prompting or more specifics about the activity. But absolutely, you are sitting there with a little sheet of paper and you're tallying. And you might not tally throughout the entire 60-minute session, but you might check in on the status for the first 5 minutes and the last 10 minutes. So that you have to measure progress. That data collection is a huge piece. And I like to hear that you ask for those sheets. You can ask.
It doesn't either, though.
Yeah, but that's part of the job, and you have to make sure that you're
And making sure it's at different times
taking
throughout the
data.
day and in different types of activities and.
Yeah,
things
we
like
have to.
that.
You have to track that data. That's how these goals are going to be achieved. You can't just walk away and say, "I felt like 60% today." So yeah, you can ask for that.
I think, so part of your question though was like, how do you determine, I don't know, if it's gonna be an 80% accuracy goal or an 85% accuracy goal or a 90%? I feel like they just kind of say, 85%.
Well, I mean, that's kind of the team decision, I think, and that's again what you think is attainable for the year. So, I think I look at 90% accuracy within this is near mastery. We think she's going to master these two sounds this year, and we won't have to have this goal next year. I think expecting more than 90% is a little challenging to do for a new skill that she's at 0 right now. But that will vary probably clinician to clinician, and that's the whole team's decision to weigh in on that goal and that accuracy. Do you have another question?
No, I just don't think that they're just like, okay, across the board 80%. I don't think it's considered. I don't think the team considers it at all. They just say, has to be a certain percentage, has to be over 70%, we'll do 75%. Okay, we'll do 80%. Or we want to have each benchmark, okay, we wanted to make it, 60, 65, 70. They don't think about it. I don't think in a more critical manner. That's just me.
Okay.
We can move on.
I think you would definitely be just catering the goal then. So if we were only, if we were trying to have 100%, we might make this more structured and take away the spontaneous sentences and say like structured conversations or spontaneous sentences within structured conversations if we wanted a higher percentage. If we only needed 60, we could just say throughout our entire day or something. So I think you would definitely should be tailoring that percentage of accuracy to the specific goal. Does that make sense? Okay. So how about the last one? You guys are good at this. Pick it apart. What's good, not good?
Clearly ineffective.
Well, I would say as lawyers, we're all sort of trained into believing that we can't know what somebody else is thinking, right? You never know what somebody else's personal knowledge is. So it kind of irritates me when I see a goal that says that somebody can effectively communicate their wants or needs, because how would you know necessarily that the other person wants or needs unless they're kind of tugging on you or pulling on you to indicate something? But then it should be linked really to that as opposed to what they're thinking. I mean, right? How could you ever?
Yeah, that's so interesting. This is
what they're thinking.
So your question is just about this kind of concern, rather about this language of effectively communicate his or her wants and needs. That is language that is used all the time.
Yes, it is.
And I
yeah. And so I think that their needs and wants, I love this conversation, this is great. Because they should be routine needs and wants, or their needs and wants during some specific time of day that are functional to their routine, so that we're thinking of kind of their needs and wants in a very basic way as it specifically relates to that day. But we have no way of knowing if she's kind of keeping something in and not communicating something. So right there, we don't like that goal for that effectively communicate. So how could we change it?
If it's basic needs of I need to go to the bathroom or I want a drink, write in those basic needs.
So
that she will ask in a complete sentence or something like that.
So would that be appropriate for this client?
I don't know how it could be effective for a speech pathologist who's only seeing the kid 30 minutes twice a week.
So effectively communicate her wants during, or her specific wants related to this activity during this small structured time, or so you have to really define what that would mean.
There could be consultation with the teacher to determine is this being generalized to the classroom, and does the teacher observe any problems with expressing needs or wants?
Well, a non-mind reading approach would be to have the child answer questions related to curriculum or volunteer during discussions at least 3 times a day or something like that. So something, a frequency goal for spontaneous participation or a response goal for a question.
So goals like this are really tricky for articulation and speech sound disorder cases, because she may be able to clearly and effectively communicate her needs and wants with a little bit of a speech error. But we know that's how Annie says bathroom, so she can go to the bathroom. It's fine. She's going to be able to clearly and effectively, I have to go to the bathroom. No one thought, oh, what's a bathroom? You all heard bathroom. So that doesn't help with her speech. So this is more of a language goal, more of a communication goal. It's not really specific to her articulation disorder.
But it occurs to me then that the speech pathologist can have a role in providing input to goals that are related to special ed or regular ed classroom. Because this kind of communication capacity could be set as an expectation for the teacher.
So the teacher could maybe write a goal like this.
Yeah, with input from the speech pathologist.
Yeah, if this was kind of relevant and related to one of the core common standards and maybe her language goal. But this, Annie does not have any language issues, no receptive, expressive, pragmatic concerns or impairment, so this would just not be appropriate for her. In addition to having the horrible language to effectively communicate her needs and wants. Can't wait to report back to my team, guys. This is great. So another kiddo. So we're good on time, right, Julie? I think we're okay.
I mean, yeah.
I feel like we have plenty of time. So this is Calvin, so he's a little bit older. He has a severe intellectual disability, and he's in the low incidence severe intellectual disability classroom. So he has a primary diagnosis of severe intellectual disability and a secondary diagnosis of autism spectrum. Are you going to talk about primary versus secondary diagnoses at all? Okay. I think that it just helps with placement in the class in a specific setting, to my understanding, that that his severe intellectual disability is kind of a primary or a higher level diagnosis that kind of gets him this spot in this particular low incidence classroom. Whereas if autism was his primary disability versus his secondary disability, he might be in a higher functioning classroom. So my understanding is that it's just which diagnosis kind of trumps the other as far as getting them placed in a classroom. Unfortunately, I have more information about that. So the teacher's main concerns are he is nonverbal, he has signs, but he really inconsistently uses this one sign for more. He'll look at you every once in a while and sign more, but only if he's highly motivated. So there's a handful of activities that she sees a more sign, but she doesn't even see it every day. Lots of sensory processing needs, very, very challenging. He kind of mouths everything. His engagement and his eye contact is very limited. He vocalizes now and then, but typically when in distress, not typically to produce functional sounds. Not ever to produce functional sounds, rather. He inconsistently responds to his name, so much so that you're kind of like, did Calvin hear me? Wasn't a coincidence, but the teacher's kind of seeing more progress in that kind of response to his name when he's engaged. And he has some self-injurious behaviors. So in addition to the kind of mouthing of things, which could be very harmful, he can't kind of get the right thing in his hands, he does some head banging, some hitting himself, and a little bit of biting. So Calvin's a very different case, right? Much more severe. So what assessment are we going to use for Calvin? So Calvin is 8 years old. He probably already has an IEP, right? So maybe he's new to the school district, or he's up for his reevaluation. So what are we going to do to assess him?
Functional.
So I think I heard somebody say it.
Functional communication profile.
Yeah, the functional communication profile. So he's not verbal, and we really don't know a lot about his language skills because of his inconsistent engagement. So we're going to just use that functional communication profile to collaborate with the team and talk about what we do know about Calvin. What are his behaviors? What are his sensory motor needs?
How is he responding to visual, tactile input? What's his level of engagement? And where's the best potential for communication with Calvin? So he has this more sign that he uses now and then when he's highly motivated, typically when he's in a swing, sometimes when he's eating. How are we going to kind of build on that? He also can kind of approximate, I think the eat sign it is. So we'll give him the functional communication profile. So we'll also do the oral MAC, right? We're going to look at him. Why can't he make speech? Is it, is there something going on anatomically, physiologically? He's got limited range of motion, but he doesn't use his mouth very often. So we expect to kind of see that he's got limited oral motor skills. Because he's not talking. We all have advanced oral motor skills because we're talking all the time and exercising our mouth. So we expect to see a little bit of limited range of motion or kind of weakness, low tone with these kids who aren't practiced. And we know that he is very picky about eating, and so he's not really practicing those oral motor skills efficiently during eating. So he's got some limited oral motor, but otherwise there's no diagnosis or syndrome or anything that's kind of preventing him from producing speech. So we gave him this non-standardized functional communication profile just based on all the information and his level of need that we were able to kind of compile and look at there. We determined that he's pretty severe, and in both areas. He's not consistently responding to his name. So he will get severe and profound, so he should get up to 90 minutes a week. So if you guys remember kind of the difference between the severe and profound, I think what they said was that the severe, let me find the exact wording for you and I'll show you this, that matrix in a minute. That a severe impairment or disorder limits the individual's abilities. So that's kind of the key word, limits, whereas a profound impairment prevents them. So Calvin's engaging sometimes. So he's got this pretty significant impairment, but does this totally prevent him from communicating appropriately? Maybe most of the time, but I don't think we can give him a strictly profound diagnosis. He's very close to there, but he does show us a little bit every now and then by making eye contact, using a gesture or a sign, and responding to his name inconsistently. Do you have a question?
Yeah, I'm not seeing why we would buy into this matrix at all. I mean, by any definition of where he is on a bell curve, totally nonverbal at 8 is way down there, profound. It's below, 3 standard deviations below the mean. And I think accepting this kind of bureaucratic language of, oh, well, if anybody can do anything, sometimes they're not profound.
Yeah, that's a good
they
question.
They have to be in a coma.
Right. Right. No, I appreciate that comment. So, yeah, this is kind of what the Illinois State Board of Education says. We think he's on the profound end, but he can gain some skills, and I think that he is showing us some good skills, and he's very severe. He's very severe. But we have to define these words in some way, right? Severe or profound. And so this is the kind of the language in the category that ISB uses. You're looking for another answer. And they really just help kind of guide the services.
Well, again, they say minimum, right? So it's not 60 to 90, it's 60 to 90 minimum. Mm-hmm. And if you were profound, it would be over 91. So
right.
I guess it just seems like this is relying on a document that, as far as I can tell, doesn't have any claim to be relied on, and then being even more restrictive than it.
Right.
Saying 60 to 90.
Yeah. And this is all based on the IEP team's decision. So all that service delivery, all of those final calls about service delivery and minutes and frequency are team-based. Just following the speech therapist recommendations. This is why you guys attend so many IEPs, right? To help advocate for your client and ask these questions at the meeting.
What would your recommendations be for speech language services?
Daily services for a minimum of 20 to
30 minutes a week, or a day. Yeah.
So up to 2.5 hours,
Yeah.
more than double what's listed there.
Mm-hmm. He would need daily services. So I think in the front you mentioned something about, you know, what we know about kiddos with autism and how they make progress, and it's not coming in once a week to try this one strategy or this one approach. It's every day.
But it's not 30 minutes a day.
It's these intensive approaches, which is why
Right.
he's in a specialized classroom. Yeah.
So Julie,
Yeah.
I think a lot of the kind of confusion here is because a lot of the, large districts here have a speech therapist that will only be present at the school with maybe 1,100 kids for 1 day a week.
Yeah.
So you're not seeing that everyday approach that, research says it's best.
Right,
I think
right.
everyone's like, oh, okay, what do you think, Because that's kind of the reality of what's happening at many of our districts.
Yeah.
I think we all know.
And they make it such a bright line. Like, well, he can't be profound because he looked at me once, therefore we don't have to give extra services, is almost what you're saying, right? Because I hear that in IEP meetings, even in the suburbs, it's not just CPS.
Yeah.
It's like, okay, we have this bright line, and I'm arguing, it's not a bright line. You can't just, and I can't tell you, it's like every meeting I'm arguing that.
Yeah.
Because they think, and it may not even be the speech pathologist's view. It's the LEA's view, or who's ever at the top. Well,
Yeah.
no, this is what is the mandates. We only need to give 60 to 90 minutes per week. That's
Right.
what we're going to do. So I think that's what you guys are getting at too, isn't it? Some of it.
I
that
mean, I
is-
would love to see 60 to 90 minutes per week in some of these IEPs that I have.
Yeah.
Yeah, well,
Well-
that too, but.
Start a due process here.
Okay, should we move on to the AAC part?
Yeah, yeah. Yeah, we can do that. And I know, Mike, you're going to talk about, which I think is kind of what we're all coming back to, is the big important piece of like best practice versus sufficient services to access the curriculum. And that's kind of the difference between maybe a private speech language evaluation that would say, here's what the research says, here's what's best practice, versus how that's being translated into the IEP document and kind of attached to these Common Core standards. Does that make sense? Okay, so let's move through. So I think you guys we don't have to look at the goals anymore. So kind of the other reason that Julie asked me to come is because I specialize in augmentative and alternative communication. So I did bring a couple. I think you're all kind of familiar with the low-tech pictures. I only unfortunately was able to snag one device today because I have other kiddos using them. But I wanted you guys just to kind of get your hands on a device, because I remember at the when I testified, people really didn't get a handle of like what a device looked like and how it was used. So I almost brought the pretzels card, but I didn't. So what is AAC? These are alternative communication strategies, right, that supplement verbal speech. So this could be anything from a picture, to a gesture, to a sign, to even a vocalization. And then kind of the higher tech kind of computer devices. So they supplement speech for those who are struggling to make their own sounds and communicate effectively. They replace speech for those who can't speak. And so a lot of systems have their speech generating, right? So they have a voice output option. And so for those kiddos that can't produce vocalizations or speech, they can't gain attention, they can't notify somebody, so that gives them a voice. And then it aids understanding. So I'm sure you guys are familiar with different picture supports to kind of help with behaviors and following schedules and just enhance participation. When you think of a preschool classroom, there are visual aids all over the classroom to kind of help illustrate all the different concepts. And so AAC kind of works in the same way. So here are some sample devices. So the Dynavox Key 10 is what I have with me today. The major kind of competitive companies are Dynavox, NovaChat is made by Saltillo, and then the Accent is made by PRC. So those are the three main companies that produce devices. Dynavox, there are a variety of others, the VMAX with eye gaze and different accessibility options. So I'm sure you're familiar with different ways to kind of rig up a device to a wheelchair or have it stationed to a table for kiddos with kind of limited mobility. And then for kiddos with trouble accessing a device with motor planning or motor coordination difficulties, they can access the device through eye gaze. So who can use AAC? Anyone who is struggling to communicate is a candidate. So I think just going back to having visuals in a classroom for preschoolers who are still learning to express themselves. So this could just be minimal visual supports. So it's AAC systems, and this goes back to kind of that ISV document, that says that so kiddos like Calvin who are not making the progress with verbal speech to get their needs met and to express their thoughts and ideas, an AAC evaluation is warranted. So I know Julie kind of mentioned before about like we see these textbooks and low-tech systems being kind of recommended all the time, and they tend to be kind of the first step for a lot of kiddos, and an AAC evaluation kind of helps make recommendations regarding those, but then also how to move to the next step. And so the research says that implementing AAC positively impacts all these things. So of course it does, right? It enhances a child's understanding and then their ability to demonstrate all of these skills. It makes all of these things less abstract, especially for kiddos who are just getting that verbal input. So children learn language through experiencing it. So I think this is something I always have to tell my parents when their child gets the device and the parent says they're playing on it, they're just playing on it. So, well, they don't get to babble. They don't get to say blah, 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 and they laugh because they made up a silly word. They don't get to talk about things they saw yesterday. They can only talk about what's in front of them and they can point to. So they love to check out that device and shop around and chat and babble on it. And that's a very important skill, you know. I have a 4-year-old daughter, and I can't count how many times a day she asks me, what does that mean? Because she just hears a new word, and she's always thinking about it. And so this is their way of doing that, and they can practice talking. It provides them the ability to do all of these things that verbal kids can do. Just make a request for a preferred object, participate in pretend play, you know, the basic things like express their needs and wants. Practice their concepts and colors. I feel like all of my AAC device users become so proficient in their colors and their shapes because those are just the fun pages to kind of shop around on for them. I think I know we're kind of cutting close on time, so pretty basic steps about all the different language and concept skills that they work on. So low tech would be more of those communication books that you've all seen, right? So just lots of us have seen these. They're filled with kind of different pages. This one has an alphabet page in it. We have kind of the arts and crafts page. And these are really common in the school, super helpful. I love low-tech stuff. I have a couple other examples of here. I did bring a little mealtime board. Then you might see these around a lot, a little ring so the child can kind of communicate their basic needs. These are great to kind of hook onto a child's belt loop or a teacher's belt loop so that they're always with them. And allows them just to use pictures to talk about things in their day or express their needs and wants. And we also use visuals to help kiddos follow directions. So use first then schedules a lot with kids. You know, first we're going to sit at the table, then we're going to go have a snack. So to help the kids kind of participate. Or the child who's nonverbal can build their own schedule and tell you what they want to do now, what they want to do next, and then what they want to do last. Light tech, and I apologize I don't have any of these with me today, but so they typically look something like this, where there's this kind of paper overlay that slides into a device, and you have to program each button, and you record your voice into it. And so it's light tech in the sense that it's got that recorded speech, so you still have that verbal output, but it's so limiting, right? It still just has these words, and then somebody has to program it, and the child can't be very independent. But it gives them that voice and that auditory model, which is really good for the ultimate goal of developing speech. And then the high-tech devices. So I have one up here, so on the break, if you guys want to, if anyone's interested you can kind of come check it out. But obviously it gets a little bit more advanced, and this is kind of a core vocabulary system, which I think we'll talk about a little bit more. But so all your core vocabulary words are on the front, and then it kind of moves into all your fringe vocabulary or accessory vocabulary words. It's a very neat system. It's called Core Power. Access methods, so we kind of talked a little bit about eye gaze. So if there are physical or mobile restrictions, you can access it different ways. So we have kiddos that this is a super hard skill. Isolating a finger and making one selection on this busy page would be very challenging for some kids. So you can kind of whittle this down, or you can get a key guard to go over here so they can't just hit the whole thing. I have lots of kids that like to do that. So you're really kind of looking at their access method. This is where I collaborate with occupational therapists constantly on this portion of my assessment, saying, can they isolate a finger? Do they have a hand preference? Would it be best if the device was kind of positioned like this? Or can they see it better here? What side of the table should we mount it on? Where should it go on their chair? The OT is really critical when you're thinking about access method. So then you're looking at the language system. So this is a pretty advanced language system. It's like a core vocabulary system. Lots of my kiddos like the more topic-based. So you're really just working on words related to specific topics. They're always highly motivated to use their device in the sense region. And then instead of building the sentence, like you would in the core vocabulary where you have to say, I want eat chips. Here you could just say, I'm ready for the swing. And it allows them just in one touch, if access is a tricky thing for them, to quick say that so that they can be the first one to the swing. And visual supports, I think we talked a little bit about schedules and stuff. What I really like about this equipment is that it has them built in. So if the room is empty, you can go in.
We can go in.
The kids love the visual supports. So do I, because it keeps me from having to make the old paper schedules all the time. So evaluations. So you're going to do your comprehensive speech-language evaluation, right? And you're going to do all the things we just talked about, probably do that functional communication profile and see what their level of needs are, and are they a candidate for AAC. So if they're not able to get their needs met successfully verbally, they're a candidate for AAC. Maybe not necessarily a high-tech piece of equipment, but some sort of supplemental language system. So it could just be signs, right? So Calvin was using signs. He was really kind of using eye gaze to communicate. Our kiddos who have apraxia of speech, we want to work a lot on speech sound production, but we also need to look at language development. So just because they can't verbalize, they're still understanding and they still want to be able to shout out what the day of the week is or what they want for lunch, but they just have limited verbal output. So AAC is really important for those kiddos who just struggle with speech production but still have so much language skills, because there's usually a very significant gap between what they understand and what they can express, and this really helps narrow that gap. So kind of depending on where, and in CPS, I think they do an extensive trial because they have access to a huge loan bank where they own several of these, right? And they can kind of assign them out to kiddos and do long-term trials with the children before they would ship off and try to get one purchased. So kind of the extent or the duration of the device trial would depend on your access to the equipment. So, but a trial period is really important because you want to find a device that can meet the child's current needs but also meet their growing needs. These things are not inexpensive, and I mean they're pretty durable and they're pretty hardy, but you want to get one that will be with the child for multiple years. And most insurances only allow for you to refund one every 5 years.
How much for that?
8,000, I think.
8,000?
Yeah.
So what do you think of the iPad-based core vocabulary? Now there's a core vocabulary, PRC has put out a thing for them.
Yeah.
There's Pro to go.
And
So people can
Dynavox
do
has
it
one.
feasibly.
So it depends on the child's needs. Absolutely. So when it comes to a dedicated device that comes from a company, you get training with that, you get tech support, you have somebody you can call on the phone all the time, you can ship the device off, get it repaired, and get it sent back to you. You can take whatever you've created, the user that you've created, and temporarily put it on your iPad while you wait for that device to be returned. With an iPad app, you don't get all that support, but that doesn't mean it's not a good fit. So some people don't need all of that support. So if you have a kiddo that's not likely to throw his device off the floor, and he can probably maintain an iPad with a good sturdy case, and he's got higher level cognitive skills or skills to kind of match the app, then absolutely, iPads are a very viable option. It's based on trials. It's really based on trials and the specifics of the app and the language system.
Do you know whether Medicaid covers any of these devices?
Medicaid covers the devices from the company, the dedicated equipment. They do not cover iPads right now, as far as I know. And there was, Saltillo, the company that makes the NovaChat, they use a Samsung tablet, and then they put their software on it, and they kind of beef it up and put it in a case. It's a very handy device with a beautiful language system. It also has the core power language. I really, really like it. And they have the visual scenes as well. And so there was some issues with Medicaid covering that because the equipment was this commercial equipment. It was a Samsung tablet. So to be honest, I don't know the update on that, is if Medicaid is in fact covering Saltillo devices yet. But I know they cover the PRC devices because again, they designed this entire piece of equipment just for their software and their communication system. Yeah. It is not easy. So before I moved back to Chicago, several years ago, I was living and working in Denver, and I was at a therapeutic day school out there where I was working with representatives from all different device companies and going through Medicaid and getting devices funded constantly. It was a therapeutic day school for kiddos, most of whom had an autism diagnosis, who were nonverbal, and who were teenagers. And until I came to that school, there was no assistive technology, no augmentative communications. Heartbreaking, and it was a lot of work, but I got a lot of devices funded in the first few years. And then when I moved back to Illinois, I got my first ever rejection letter from an insurance company. So one of the representatives here said that it's a little bit harder in Illinois with Medicaid than it is with Colorado Medicaid. So it seems like there are some additional hoops, but it is definitely possible to go through private insurance as well.
If you ask for an assistive technology evaluation, will it encompass this, or do you need to specifically say, I want an AAC evaluation?
So they're slightly different. So assistive tech could be anything from like additional padding or mats in your wheelchair, or a weighted spoon for them to help facilitate eating, a larger keyboard for maybe visually impaired kiddos. So AAC is really looking at the communication.
But you should specifically ask for this. You shouldn't just assume it's encompassed with the assistive technology domain.
I wouldn't assume.
Okay.
Yeah, I would make sure. You know, it's unfortunate because sometimes those two terms are used interchangeably.
Yeah.
Mm-hmm. So I think I would make sure that you had both. Yeah, it's a great time. So there's just a few resources. I use this all the time. I don't have access to a large bank of loaner devices. There sometimes is a long wait list. I use a lot of low-tech and light-tech stuff with my kiddos, so I get it real quick. Waiting for devices like this is a little bit longer. It's worth the wait. They're wonderful there. Anyone can borrow the device. So in preparation for kind of trainings like this or other opportunities, it's worth it just to kind of check them out. Especially if you have a kiddo where you think, they should have given them an AAC device. What can they do? Help get them access to some equipment. And a private therapist or whatever can help with that. But even family member can trial some of this equipment. Just other references. So there is the matrix is on here somewhere, right? It's at the top. Yeah, and Julie, if you don't mind making copies, I don't know if you guys want a copy of that matrix or not. Yeah, any other questions? Well, thank you guys for asking so many questions throughout. I am a big speech therapy geek, so it's nice to kind of sit here and talk about wording for goals and yeah, lots of thoughtful things I'm going to take back to my team for sure. Yeah, thank you.
Thanks, Julie. And the bathroom codes, by the way, are on the front door, so if when you walk out there, 124 for women and 421 for men.
We're going to do process.
So we work with him.
So the next thing we got a call from the superintendent inviting us in, so I brought my son in. I brought my husband because we're not allowed to record the meetings. I brought my husband because he listens and cooperates. I brought my son. Well, she's the superintendent. And so when you misunderstood the nature of the meeting. And I said, I don't care what the nature is. You have your doctorate in education. You're going to hear my child read. Pick a book. She picked a book. It took 15 minutes for her to, what do you want? She goes, what do you want? I said, Pathology and all the main parts. She goes, well, if you think he has Apraxia, why do you want that? Radio, TV, nature. I would swear my life he has dyslexia. Despite the fact he's a doctor. However, you need to evaluate him. Outside evaluator knows what the grades maybe. So then she goes, but we get to pick the evaluator. I said, no. Under the law, it has to be mutually agreeable. She says, well, we agree with this guy. I said, I don't care who you use, you're not using that. Right, so that's another law.
And all the offices are connected, so.
Yeah, everything is out of there.
And you sent her back.
So you're a lawyer? I am a lawyer, yes.
And is this your main field?
Now it is, yes, because of my child. I may be needing guilt. And technically, our school district is pretty different.
Her background is in for many years.
I do this for people trying to tell them I'm low Asperger's. But I really, it's more special needs because I've never been so many. I'm not a very good
And then,
by any means, several years later.
And
My son was in kindergarten, and I started volunteering in school. And then realized, why does she have all the IEP kids sitting together? She keeps separating them. Why is my kid with ADHD diagnosed at 4 sitting with his back to the
We're missing a few people, but let's go ahead and get started so we can get through everything.
You ready?
Yes.
Okay. I'm Mike O'Connor, and I've been asked to follow up Julie Dem's remarks with some of the legal aspects of speech-language evaluations. And in your packet, my outline starts at page 25, and I'll go through it on the screen up here as well. A couple of preliminary observations. I've been working in a small firm, 2-attorney firm, Walker O'Connor, for about 10 years, doing exclusively special education representations. But my background has been in legal services work. In fact, I rented a desk from the prior director here, Sheldon Rudman, when I was director of the State Support Center. And I spent other time in New York City and in Buffalo doing primarily class action and appellate litigation. And I offer a general observation that special ed practice is the most complex and challenging legal work that I've come across. Because it's not only mastering the legal aspect, which every area of practice you deal with. Layered on top of that is a set of multiple specialists, ranging from speech to psychology to occupational therapy to physical therapy. And you have to be able to talk on a pure level almost with each of those specialists. And then on top of that, the third level is that all this has to be put into an effective educational plan. So all that together becomes very challenging. And I think this is a great training opportunity to combine expertise from a practicing speech pathologist with some of the legal aspects and also the practical experience that I've gone through and looking at evaluations, critiquing them, and working with speech pathologists and other specialists. One other observation is that I know some of you are on a pro bono panel, others of you are working in either an LAF or Equip for Equality. Can you hear me all right?
Yes.
And I would just recommend, I'm somebody who comes out of the legal services, I cannot imagine telling a parent, I'll get your son an IEP as soon as you give me $5,000. Our firm does not operate like that. We primarily represent low, very moderate income families. and we've been doing it for 10 years, and we're making a living at it. So I would recommend that you look at special ed practice as a potential area to go into and make a living. There's 50,000 kids in Chicago with IEPs, and an awful lot of them need somebody to represent them. Now, with respect to my presentation, I'm going to address the legal basis for evaluation. It's going to be somewhat generic, related to evaluations under IDA generally, but I'll also touch on speech-language issues from time to time. And this is really one of the more fundamental aspects of practice under special education, because the ultimate goal, FAPE, free and appropriate public education, is really based on an accurate assessment of what are the kids' needs, the severity of the needs, and then what kinds of services are required to remediate those impairments. And without an effective, adequate, appropriate evaluation, you're not going to have a good plan, a good program. All right. So in terms of the basics, well, before I get to the basics, let me mention that on page 7 of my outline, there's an appendix listing a whole series of URLs. And if you should have gotten a copy of this electronically,
Yes.
the digital version. And I would urge you to look at this, because these URLs are live in the digital copy. You just click on it, and it'll take you to the public law for IDEA or the U.S. Code, the Federal Register, the school code, state regulations, and the series of ISBE contacts. And I may try to click on one or two of them when we go through here later on. Now, in terms of the basics, child find. I want to talk a little bit about child find, because that underlies a big part of the school district's obligations, and that the child find provisions of IDEA require that a school district identify, locate, and evaluate all children who have or are suspected of having a disability. And that suspected part is key. And that goes back to some of the things that Julie was talking about in terms of just indicators, flags that suggest that a kid is struggling, enough of those should create or trigger the obligation to do an assessment and, if necessary, do a full evaluation. All right. Now, the evaluation requirements, I've listed there. I pulled 7, what I thought were the most critical ones from the federal register, from the Code of Federal Regulations. And so again, it's a matter of looking at all areas related to a suspected disability, and the evaluation must be comprehensive in order to identify special education and related service needs. Now, special education involves direct services in the classroom by a special education teacher. Although it can include direct services in the communication disorder classroom with a speech pathologist who also has a teacher's certificate. But related services include speech-language services, as well as transportation, occupational therapy, physical therapy, social work, school nurse services, a variety of things that are necessary to help the child access the educational curriculum. Okay. Now, item 3, the assessment tools, there must be a variety of assessment tools and strategies to gather functional, developmental, and academic information. And I want to stress that it's not just academic. It requires looking at functional and developmental status, as well as whether or not the child is functioning at grade level. Item 4, Roman number 4, small 4 is properly administered. That's a formal requirement that norm tests or other formal evaluations have to be administered in a way that's consistent with the way the test was designed. Item 5, not use any single measurement or assessment. So there just should be multiple approaches to look at whether or not a child has an impairment and to assess the degree of severity of that impairment. Then item 6 is looking at existing evaluation data. That's looking at the school records, the prior evaluations, looking at any parent-provided information, any private provider reports. And then the evaluation process is really like peeling an onion, and that you're presented with some preliminary indications of potential need. There may be some testing done, and then that often suggests a need for other testing. So there should be, the testing which should suggest the need for additional testing should be set out and followed through on. Okay. So then I also list here the formal, and Julie touched on this a bit. The formal definition of speech-language services in the U.S. Code, and the definition of a communication disorder. Now, the speech-language impairment is one of several formal disabilities that can qualify a kid for special education services under the IDEA. I mean, the most common are speech-language, emotional disturbance, autism is up there, but communication disorder or speech-language impairment can be a separate freestanding basis of disability, although it's rare, and I can't recall a time when that's been the only disability that qualifies a child for special ed services. And then, again, there's a list of speech-language services, ranges from the identification, diagnosis, appraisal, and appraisal. It can be a referral for medical and other professional attention, as Julie mentioned. And then delivery of speech and language services, and then counseling and guidance of parents, children, and teachers. And that last part can include the consultative services, and very often in IEP you'll see a certain amount of direct service minutes, and then there'll be additional minutes listed for consultation. And that's typically, in my experience, targeted on the classroom teacher and possibly other related service providers like the occupational therapist. But it can and often should include counseling and guidance for the parents. Right. And then assistive technology. Again, the Code of Federal Regulations under IDEA refer to AT services and AT devices as maybe that are made available to a child with a disability is required to provide special education services or related services, and then there's supplementary aids and services under another section. And so this altogether includes both equipment, such as what Julie was describing, the Dynabox, but also any software that may be used in the equipment, and the training and support that's needed for the provider to effectively use it with the student. Now, I thought it'd be useful to talk a little bit about categories of evaluations. And any evaluation, including speech evaluation, can come up in several contexts. One is the initial evaluation for a child who's not yet eligible for special education. Then there's once the child is found eligible for special ed, then there should be a follow-up comprehensive evaluation at least every 3 years. So both the initial evaluation and the 3-year evaluation should be comprehensive in a sense that it goes back to covering all areas of suspected disability. But then two other categories are the special evaluation, which is an evaluation that's outside the 3-year period. And one example might be a kid who's got an IEP, has the initial evaluation, and at the end of the first IEP year, you discover that the child has not met some goals. And one option might be to do a special evaluation to see if we got this right. Is there something else that we missed? And maybe the experience of not meeting the goals suggests that there's some other areas that should be evaluated. So that would be a special evaluation. And at any point, a parent can ask for a special evaluation. And I'll get back, I'll come back, I'm going to be doubling back to these things as we go further along. And then there's the independent educational evaluation at a public expense. This is Schaefer versus Least is a Supreme Court case that kind of put this on the map in terms of it being available at school district expense. Schaefer versus Least was primarily about who should have the burden of proof in a due process hearing. And Sandra Day O'Connor wrote the opinion. And in order to rebut the proponents who said that the school district should have the burden because they're relatively more powerful than the parent, she went through a number of different aspects of the process and focused on the independent educational evaluation and simply said, well, a parent can request an independent evaluation and the school district has to pay for it. And so she used that explanation as one of the reasons why the parent should have the burden of proof when they're pursuing a due process case. Now, the big catch there is that, yes, a parent can request an independent evaluation. They don't have to say why they want the independent evaluation, although it's useful to lay out what the problem is, because to the extent that there are significant and obvious problems with the evaluation, maybe the school district will agree to do it. But the school district doesn't have to agree. The school district has two options. One is to agree to pay for the evaluation, or they request a due process hearing. And what happens at the due process hearing requested by the school district is that they have the burden to show that their evaluation was adequate and appropriate. And in my experience, that can be very challenging without your own independent evaluation already in hand. I've gone through a number of hearings with variations of getting the evaluation and then presenting it at the hearing, not getting the evaluation because the parent lacked the resources to do that. And I've had big success. I was able to, and we'll have a few due process cases here where I'll go through as sort of case examples where I was successful, or our firm was successful. But also I've had a number of cases where I was not successful. And the problem of going to a hearing on an IAE request where you don't have an outside evaluation in hand that identifies impairments and degree of severity that were ignored or not adequately assessed by the school district is that you have to have something, because the school's going to come in and say, well, we did our evaluation and our speech pathologist interviewed the students and interviewed the teacher and observed the student in the classroom and determined that there appeared to be no functional impairment or language problem that affected academic performance. And when you have that testimony from school staff and the school speech pathologist, you've got to have something else to rebut that. And I've had several cases where we would have somebody do a record review and comment about the apparent needs of the child that were not properly evaluated. And in a few cases we've succeeded, but recently we've not been able to succeed in that manner. And what I think is happening is that the hearing officers are being trained to take the position that when there's an IE issue, there has to be an evaluation in the record that is used as a basis to find that the school district's evaluation is inadequate. That's the pattern that I've been seeing. So let's go on to E and F. Private evaluation it's like an IE, except that the parent, it's not yet an IE. The parent can simply get an evaluation at any time if they want to, and they can afford it. Now, even with lower income families, I've occasionally been successful in getting private evaluations done by hospitals like La Rabida, Children's Comer's Hospital, UOC, and then some mental health facilities will occasionally do an evaluation. And I've even gotten speech evaluations done by a speech pathologist at La Rabida, the Children's Hospital. But that's fairly episodic, and a lot of the parents of Chicago Public School students, particularly on the south and west side, unless the kid has got some pretty severe, exceptionally severe impairments, is not going to be involved with a hospital on a regular basis or an outpatient clinic. And Medicaid, I found, is not a resource that you can use to do an effective evaluation. It just doesn't pay an adequate amount. So I guess one place that we've looked to from time to time is for private evaluations for lower income families. Sometimes the family would go on a payment plan, and if the provider is willing to do that, that's fine. There's a few occasions where our firm will advance the cost. There's a certain amount of risk in doing that, and it can create some questions if that comes up in the hearing, which it often does. But that's still another option. And then there's always trying to get a pro bono evaluation. And, and we've been able to do that from time to time, but there's only so many times you can go to a clinician and ask them for a freebie. So it's really, it's a real dilemma. Evaluations ordered by the hearing officer, there's a provision for that, and that's happened just a few times in my experience, where the hearing officer will, in the middle of the hearing, decide, you know, I can't decide this case without an evaluation. So they'll stop the hearing, and I tend to treat it as an IEE and take the position that the parent should select the evaluator. I've gotten some pushback on that from a few occasions, and the worst that I've experienced is that I would develop a list of 3 evaluators, and the school district would pick one of the 3. That was sort of a compromise that the hearing officer pushed us into. But one issue with that, there's a good part and a bad part. The bad part is that it'll delay the hearing 2 or 3 months, because for some evaluations, you can't just call up and say, can I get a speech evaluation next week and the report the week after that? You know, it takes time to get into somebody's schedule. And and usually it's more than just a simple test. There's a need to look at a lot of records, and you may want to try to have an observation done at the school the kids attending. There's a lot of things they can spread it out to take 2 or 3 months to get a report in. The good part of something like that, and it's also one of the potential negative parts of an IEE, is that you have the evaluation put into the record, and you continue the hearing with testimony from the outside evaluator. It helps you to build the case related to FAPE denial. Now, of course, usually if you have an IE request that's pending, and you have usually you file a hearing request related to FAPE as well, and eventually you're going to have a hearing on the FAPE issues with the IE. The timing of all that, I'm going to come back to that in a few minutes to discuss the various options of how to follow through on that. The next thing I wanted to go over is some procedural issues in the evaluation process. At the very beginning, there's the initial referral or request. Now, sometimes the initial referral comes from the classroom teacher who writes up a form, sends it to the case manager, and basically says, this kiddo's not doing well. I think he may need special ed services. Let's do an evaluation. It may come from the parent. When I'm working with a parent for a child who's not eligible, what I usually do is I'll work with the parent to write a written request for the initial evaluation. Now, once they get that request, within 14 days, there should be a written response. And the response should say, yes, we'll do an evaluation, or no, we won't. If it's no, there should also be the notice of procedural rights. That's that 12, 14-page thick list of the rights that's issued by ISBE. If it's yes, then the next step is the domain name. And I'm going to see if I can jump to the forms that I had in the appendix. Appendix A. Yeah, so here's the URLs that you just click on. Before well, I'm right here. Let me just go right here. You know, I did this before and it worked. Oh, here it is. No, this is the URL I just clicked on for ISBE due process decisions. And this is a useful resource because it lists all, it's not very timely. And they're like 6 to 8 months behind posting them. But it lists these decisions that are issued. And you can sort it in 2 different ways. So that, that right now it's sorted by this column. So that you have all the decisions issued by in fiscal year 2015. And fiscal year, by the way, starts July 1st. And so for this fiscal year, there's only about 14 decisions, and we're more than halfway through the fiscal year, because fiscal year 2016 starts on July 1, 2015. And the other observation I would make is that where is this here? Like 2013, 490, they go up. The numbering starts 001 for due process requests filed after July 1 each year. And so generally there's around 500, because here's one with a high number, 2013, 496. And then down here there's the 2012, 511. Now you can also sort them this way, and this by from the bottom forward, or from the top down. So here's the 2014 file. So there's about 500 due process cases filed each year, but there's only 30 to 40 decisions issued each year. I'm astounded at how low that is. And then the other thing is, if you ever have a hearing coming up with somebody, you can click here, and I won't scroll down, but now this is sorted by hearing officer, by alphabetically. So, you know, you can dig up, if there are any. There's a whole bunch of newer hearing officers that don't have much of a track record. Let's do this. All right, so I was in a process of, I interrupted myself here. It's getting down here to here's exhibit appendix A, and this is the so-called domain form. The first form looks like an IEP cover sheet, and so what happens after the request for an evaluation, if it's approved, there should be a domain meeting. And also, the domain meeting should happen for a triennial evaluation and a special evaluation, okay? And the purpose of the domain meeting is to convene the IEP team, including the parent, to discuss what areas should we look at? What are the areas of concern? And the product of that meeting should include this cover sheet. It looks like an IEP cover sheet, except it's for an assessment plan. And it should list all the people who were there. And this is a redacted version of a domain meeting that was held just a few weeks ago at Cove School. And then, so after the cover sheet, there's a consent form. And this has just got boilerplate consent. Any evaluation conducted by a school district requires parent consent. And so this form is used to collect the parent's consent. And see here at the bottom it says, I give consent, or do not, to collect evaluation data described on page 2. And also you see right above there, it acknowledges receipt of an explanation of procedural safeguards. All right. So the key part of this is the domain sheet itself, which is this series of boxes. And it's the various domains of, you know, in an initial evaluation or a triennial evaluation, most of these boxes should be checked yes. This was a special evaluation for a kid who had been transferred to Cove, and the staff there said, well, we want the OT and the speech pathologist to do an updated assessment because we think there's some things that need to be addressed. But I think it's important to be aware of this form and to be on the lookout for it, because it can have information that can be useful in assessing the adequacy of the evaluation, because there's often anecdotal information put in various places that suggest flags for the need for evaluation in other areas. But here it says, you know, it says hearing. Now I would say, in a very technical sense, hearing is checked no, but the last hearing assessment was in 2009. That's over. He's overdue for a hearing test. It just wasn't raised at this meeting. It looks like he had a triennial evaluation in October 2012, because that gives you the prior dates of assessment. And it looks like there was a special evaluation in May of 2014. And there's no information here about general intelligence. So again, that would be where the psychologist would put in what information they have, what information, what evaluations they intend to do, and where they're going to get it from. And so here is just this speech language assessment, and there'll be an updated speech language assessment, and the Cove speech language therapist will do it. Now, I'd say Cove is kind of a special case, because that's a therapeutic day school that has generally got a pretty good reputation in the community. I would not, and sort of you, in effect, trust them to a certain extent. You trust them to just do what they think needs to be done. I would not consider that to be acceptable in a public school, as far as, because just to say updated speech language assessment, you don't know what that means. They should put in some more specific information about, are they looking at receptive language, you know, articulation, what is it they're going to look at? We've even gone so far as, to the extent we have input into a domain meeting like this, to ask them to put in specific tests that they're going to administer, rather than let them pick the test, because we've seen them say they're going to look at a particular area and select a test that really wasn't adequate for it. Okay.
So my strategy in California has been that I don't tell districts what test to use. I just have the parents sign. If there's some area of suspected disability the district might know about, I get the parents to bring that forward, but I don't want the parents micromanaging, partly because I don't necessarily want the district's assessment to be good, I want to be able to ask for an IE afterwards. So with rare exceptions, I would not participate heavily in this process. Plus, in California, we don't have meetings for this. Do you
Well,
participate actively in domain meetings? What are the
Generally,
strategic
prior to a due process case, we don't do IEP meetings or domain meetings. We may be consulting with the parent in the sort of background, as the case is sort of evolving. But I've not found it very useful to go to IEP meetings generally outside of the due process milieu, or the domain meetings, because then the school brings in an attorney and it changes the dynamics, and very often the lawyers start fighting about stuff that's not that relevant to what the kid needs. There's different approaches to this. I guess I would necessarily say I want to set up the school to get an IE. Although, if we ask them to do a specific test that we have reason to believe is appropriate and necessary, and they don't do it, well, then that's setting them up too. And if they do the test and they don't administer it properly, or they don't interpret it properly, or they ignore the findings, then that's also setting them up. So, I don't know. But anyway, I went out of my way to point that out, because I think it can be a source of useful information. Because, well, for example, here it's updated occupational assessment, fine motor, sensory, executive functional utilization. Those are areas, and I'm getting outside just speech, but those are areas that are often overlooked by school occupational therapists. And because occupational therapists tend to think of OT as mechanical. Can you button your shirt? Can you zipper up your coat? And when you get into these areas of sensory and executive function, they look at you like, what are you talking about? And if there's indications of those kinds of needs elsewhere, then it often turns up that something elsewhere in the document references these needs, then you've got a hook. So after the domain meeting and the evaluation should take place, it should be given to the parent in advance. Now, very often we don't see that happen, but ideally the evaluation should go to the parent prior to the IEP meeting. Sometimes they get it at the meeting. One important, let me double back to my outline here. Yeah, the IEP team then should convene and review the report. The speech pathologist should be at the IEP meeting. We sometimes see IEP meetings that review reports, and whoever issued it just wasn't there. They could theoretically get away with it if they had a substitute speech pathologist come in to review the report. But if there's no speech pathologist, if there's a report indicating speech pathology needs, and there's no speech pathologist at the IEP meeting, well, then that's a definite violation. And then the IEP meeting should take place, is required to take place within 60 school days. That's actually a long time. That's school days. So that's the equivalent of 3 months. Usually more than 3 months, because if you had the consent, and it's after the day, 60 days after consent, parent signs consent on November 1st, and you've got Thanksgiving break and Christmas break, you know, non-school days, you know, you're looking at 3.5 months or more. Now, the other issue is what happens if consent is signed in, like today, end of April, beginning of May. You're not going to have 60 school days is like well into the next school year. The school code provides that there must be an IEP meeting at the beginning of the next school year. If the 60 days runs out during summer vacation, if the 60 days is not runs over the summer break, then the school district's required to complete the evaluation and have an IEP meeting at the beginning of the school year in September. Okay. Now the way CPS does that is that they, when they're pushed to do it, they have a so-called summer assessment team, and usually there's 1 or 2 schools that they have a team of psychologists, OT, speech pathologists, nurse, social worker that are there all day for like a month during the summer, and they do evaluations. They couldn't be done, and I've gone through that several times, and I can't think of any occasion where it's worked out well. And the problem, it's a series of problems. One is they lack access to the full record for the kid. Often the entire school file is not available. They don't have a chance to talk to teachers or other staff involved with the kid. They're often hurried in doing the evaluation. They'll try to do you know, a comprehensive 3-year evaluation or an initial evaluation by 3 or 4 different evaluators in one day. You know, it's just like crazy. It should, you know, probably should take 3 or 4 days, because very often a kid can do testing for a couple of hours and they may burn out. So those summer assessments have not, in my experience, worked out well. But it also, again, can set up a situation where they're creating an opportunity to get an independent evaluation. Okay. All right. Now, so I want to go over evaluating the evaluation. And this gets into some questions that were being asked of Julie, like how do you figure out the evaluation is not good? Yeah, was there a question?
That's a really good question about the summer assessment, your experience with summer assessment. Do the team who do the summer assessment, do they participate at the IEP meeting at the student's school in the summer, or?
No, usually they write an IEP right there.
Okay.
And they try to do that in one day sometimes, you know, I mean, or 2 days even, you know. No, the IEP team consists of the summer assessment team, which adds another layer of difficulty, because then the school gets this IEP that they've never seen before and don't know why are we doing this, you know. So evaluating the evaluation. My urgent recommendation is, at the initial interview with the parent, to be thinking about the potential need for an independent evaluation. And also that the initial interview, to the extent feasible, include the child. I feel it's very important to eyeball that kid and try to engage the kid and you know, just measure things about, you know, how are things going at school, to the extent that they're able to communicate. As experiences, you know, with teachers, you know, how they like their teachers, how they get along with other kids at school, what's their favorite subject, least favorite subject. If they already have an IEP and calls for speech, ask about the speech pathologist. Do they know who it is? Do they know the person's name? How often do they see that person? And even if the kid has, you know, is not able to communicate effectively at this level, you know, having the opportunity to see a kid and see how they're interacting and how they're dealing with a relatively strange environment, your office, can help you as you look at other records and documents, and also as you talk to the parents. So I think it's absolutely essential, I think, that you have direct observation of the kid. I think it's also important to dig out of the parents are not always totally forthcoming about everything that's been going on. And they think, well, this is for school. And the fact that I was getting speech services in La Rabida for 2 years, I mean, that's La Rabida, this is school. I mean, you have to, in effect, gently cross-examine the parent about all the various service providers that they've dealt with. And there's also, going back into medical history too, there may have been private therapy, private tutoring, there may have been medical issues like ear infections. A kid who's had a lot of ear infections, they have tubes in their ear, is at high risk for developing auditory processing difficulties. So, again, the issue of whether or not there's going to be a need for an outside evaluation ought to be on the radar screen from day one, and these are ways to begin attacking that. The other step is gathering school records, and so it's a matter of getting all the school evaluation reports, protocols for tests administered by evaluators. Now, what's a protocol? Protocol is the test answer sheet. Now, some of the tests that Julie was describing are relatively informal, but any test that's a formal, standardized norm test has an answer sheet, and the evaluator should go through the questions, write the answers down, or in some cases, the student may write the answers down. Grade the responses, add up the score, and put that in the folder with the evaluation report. And they're required to keep those. And getting the protocols, it's absolutely clear that the protocols are school records. And for a while, there were some fights over whether they were copyrighted, they couldn't be copied, and stuff like that. Now, they're required to produce them. And it's amazing the kinds of mistakes. Well, I'll come back to that in a minute, but it could be a source of identifying major errors in the evaluation that can lead to an IEP. So again, I mentioned domain needing documents. All the IEPs, there's a lot of anecdotal information in IEPs that can be used to flag areas that were not assessed at all, or that seem to have been assessed inadequately. The IEP progress reports. You know, there's a report card, and then along with each report card, there's supposed to be an IEP progress report on each respective goal. I've seen fewer and fewer of those as time goes on, but they're supposed to be there, and to the extent they are, they can be a source of information. You know, Julie mentioned the notes related to assessing whether a child has 80% accuracy or 90% accuracy. And I'm thinking, you know, I don't recall ever seeing anything like that. Has anybody ever seen?
You have to ask for them.
Yeah.
Yeah.
But
they've never volunteered it, but.
Yeah. Well, I mean, I've always thought that in effect we asked for everything, but the specific folder that lists week by week the degrees of accuracy in responding.
And that's what I say, I want that little tally, how did
Yeah,
you
yeah.
assess? And then they'll say, oh, we do blah, 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 and I said, well, I want that tally sheet that you used with, and then they're like, what do you need it for? Well, I just want it.
Yeah.
Usually they don't like it.
Well, they don't like to give it up because, you know, it creates paranoia for them.
Exactly.
Being looked at. But also, it may be that they haven't done it.
Well, or they've only done it twice, and that was 2
Yeah.
weeks before, 1 week and 2 weeks before the IEP meeting, so.
Now, another item is related service provider progress notes. You know, every contact between a speech pathologist and a student, they're required to record the date of that event, who they saw, how long it lasted, and what services they provided. And then they may record some other things like, you know, went well, Johnny was very upset and I couldn't engage him, but or you know, he wasn't there because he was suspended, and there's no suspension on the record. It's all kinds of things can come out of those progress notes, because they're usually, if not contemporaneous, they're done within a week or so of the service, and there's no thought given to, you know, what the context that somebody might look at this down the road in a due process hearing. Email correspondence is also can be golden, and it can be also very difficult to get a hold of. But again, parents can be a source. Even I found that even lower income parents are using email, and to the extent that they've had email correspondence with teachers, related service providers, or even administrators, you know, it can be very helpful. And you know, I had one hearing where we ended up subpoenaing people from downtown because the parent had email exchanges over problems with their child, and you know, getting kind of a runaround, but some promises that things would be done. But also, each email usually is a sign that there's something else going on. So there's usually a chain of emails, and if you get one or two from a parent, and there's some indication that somebody else has responded from the school district, you just start. They give you an opportunity to argue with the hearing officer to order production of more emails that otherwise wouldn't come out. And finally, incident reports, misconduct reports can be valuable. It's my personal view that there's an awful lot of kids that are acting out in school, in part because of language and communication problems. They may have low frustration, they may have PTSD because they've seen a friend get shot and other kinds of violence. But there's also pragmatic language skills may be weak. They may just not understand things very well, it increases their frustration. And all that stuff comes together and leads to emotional outbursts. So I always consider incident reports and misconduct reports as a potential source for flagging the need for additional speech language assessments and services. We already mentioned private provider. And something I haven't mentioned too much is speech language, the need for AT evaluations. I think any kid with any kind of a limitation in expressive or receptive language, either oral or written, is a candidate for assistive technology. What's a little bit strange in this domain is that there's really an absence of, somebody was telling me that there's somebody who's certified, they knew somebody who's certified as an AT provider, but I haven't been aware of any formal certification process for assistive technology, and there's no formal testing. What it usually consists of is the teacher is assigned to be the AT person, or you have somebody like Julie who's taking this on their own. And they develop an expertise in the equipment that's available, and they go in and they meet with a child, they look at the records, they see and they experiment with some various technology resources and see what seems to be able to work. And then they meet with the IEP team and say, well, we should try this, this, and this. And that's kind of how it goes. And my experience with CPS is that they will, I mean, they're about to go into bankruptcy, I think, and they're very broke. And I don't think we've gotten a laptop computer for our kid except through due process. And usually, even then, it takes 6 months to get a laptop computer that works. Yeah.
Yeah, Mike, I've had like similar experiences, I think a lot of us have, but it's, you know, a lot of the most common one that's being recommended is like the talking dictionary, you know, versus like an iPad or something that maybe a kid would actually want to use and utilize in the classroom at home. So I don't know if, you know, I know you said you're going to mostly hearings, like, is there, in your experience maybe with IEPs and stuff, is there any way to say that they need this? Because they're saying there's one in the classroom. Well, yeah, there's 20 kids in that classroom. They don't really get to utilize it in a real way. So
That's right.
I'm not finding that easy.
Well, that's where I think as part of an independent evaluation, I mean, what you're describing is inadequate assessment for AT needs and an inadequate implementation of AT services. And the response that I would push for would be an independent evaluation of AT needs. And, you know, all the work that I've done in AT has been with a speech pathologist who, like Julie, has got expertise in assistive technology. And she would combine, as Julie has done, a speech evaluation and an AT evaluation. But beyond just doing that, you know, pulling out some equipment and trying it out and seeing how a kid responds. And very often, kids will respond very positively to a warm opportunity to do something that they've had trouble with before. But a classroom observation to really nail down how inadequate the implementation is, we always try to have the outside evaluator do a classroom observation, whether it's speech or assistive technology, and both observe the kid in the classroom and interview the teacher. And both those activities are protected in the school code. And although, you know, sometimes teachers are less than forthcoming, you know, when we run into a real problem, we've gone to a hearing officer and said, you know, our evaluators tried to talk to this teacher 3 times and she's not available. The hearing officer would kind of lean on the school attorney to make it happen. Those are, I mean, so that's sort of an independent evaluation that looks separately at what the kid needs and also looks at what the kid is getting. I think is critical in overcoming schools' resistance to providing these additional services and additional equipment. Also, you know, as part of the outside evaluation, they can look at the equipment that the students have been given by the school and see what test their facility with it. And if the kid's been using, you know, supposedly been using a Franklin speller for 6 months, and this teacher saying, oh yeah, it's great, it really helps it a lot. And the private evaluator pulls one out and discusses, goes over it with the kid, and the kid says, yeah, I've seen that once or twice, but you know, it doesn't really work, and you know, and I don't really know how to use it, and you know, so you can kind of use that evaluation to poke holes in the school district's position. I'm gonna have to move along. This is, you know, you always do these things, you wonder how you're gonna fill up the time, and then you find out that you've got too much. Well, you know, to jump on down a little bit, you know, evaluating the evaluation, I mean, based on reviewing all the school records and talking to the parent and the child, you just look for flags that suggest that there's an area that should have been addressed or was inadequately addressed in the school district's evaluation. And then you look at the, as I said, the test protocols. And you know, over time, you develop enough expertise to begin to evaluate an evaluation and see when there's some major flaws. But you know, I am not ever going to be a speech pathologist or have the capacity to formally make those determinations. So what we end up doing is sending this stuff to a consulting speech pathologist. And ideally, it's somebody who's going to do an evaluation, and you want to send all these records to them anyway to help them do an effective evaluation. But part of that discussion is, do you see what I see in these evaluation reports? Are they as bad as I think they are? And now here are some examples. That affect the reliability of school district testing. An obsolete version of the test. Julie mentioned that there's some tests that come out every few years, others come out every 10 years, but there's a tendency to update the norms at least every 10 years. And you'll see tests like the OWLS 2 or the PPBT 4. That's the version, and schools should be using the current version. Now, if a new version comes out, they may have a few months to use up their old stock, but you know, if they're using a version that's 7, 8, 10 years old, well, that destroys the validity because it's updated for new norms. This person has since retired, but there was a CPS psychologist that really liked to use an IQ test was normed in the 1930s. and she kept using it, you know, and every time, you know, she always set herself up for that, and thankfully, thank goodness she's retired. But, so obsolete version is something to check on. And you can also check on these by any test, just go Google it and look at a website, and you'll see what the current version is. Also, it's not, you saw that some of the tests were marked like 2 to 21. Well, some are like 3 to 7. You know, there's age ranges, and if they do a test normed for 3 to 7 to a 10-year-old, then that's not good either. Non-standard conditions. Now, what I've listed there, the student didn't have eyeglasses, was excessively tired, testing room was crowded and noisy. Actually, and those are serious enough that I would say the test should have been dropped and rescheduled for those reasons. But at the very least, the evaluator should say this was non-standard, and this is the reason I went ahead of it. And if they sort of begin to cover themselves a bit, if they at least explain why they went ahead with the non-standard. All right, failing to administer a test is indicated by other testing data. So, I mean, you know, as Julie said, if you're hearing reports of a kid, you know, being told, having received directions 3 to 4 times, that's suggestive of a receptive language problem. And then another one is failing to administer all subtests that are indicated. Now, Julie mentioned the SELF, Comprehensive Evaluation of Language Fundamentals. That's a good test, and she said there's 10 subtests. And then she said there's a core test, I think about 4 or 5 subtests. And then she says you can do the other subtests based on what you found. Very often they'll find CPS evaluators will not even do all the core tests. They'll do a couple of tests and say, okay, that's all we're going to do. And that's just inadequate. Now, there's errors in the administration of the test, and some of this is where you look at the protocols, and these are some examples of errors that we have found in the protocols. One is not setting the basal and ceiling. some tests will have like 50 questions, and if it's normed for like 3 to 21, they'll tell you to start a question, based on your age, based on the child's age or grade level. You start the test at a certain point, and then if they get a certain number wrong, you go back up to a more basic level. That's called setting the basal, because you have to establish the can function at a certain level, and then you start testing from there. And then you go along, and then you reach what's called a ceiling. And that's defined as various tests. It could be missing 5 in a row. You could be missing 3 out of 5. And at the point where that happens, you stop the test. And we've seen protocols where they've ignored that. They'll start the test right at the first one, and then continue on beyond where they should have stopped. And we've had our evaluators have come in and said, well, that's improper administration and makes the test results unreliable. Others are not recording the answers properly and not adding. Julie mentioned prompting. There are some tests where a kid is struggling and you can give a prompt once. And you're supposed to note in the answer sheet what the prompt was you gave. And then if you give a prompt, that affects how you score it. So we'll see places where the prompting was done, but the result of the prompting wasn't accommodated in the scoring. And even more basically, not even adding up the answers correctly. Somebody will get 25 right, and they'll write down 27 as a raw score. And that'll end up pushing the standard score up several points. It's just amazing to me that these kinds of errors not only happen. I mean, somebody like Julie is aghast at this stuff because she's conscientious and professional. But we see these errors being made not only when nobody's looking. I've seen these kinds of errors made when they're testing while a due process case is pending. Yeah.
So in the case that I have going on, the district lawyer told the speech therapist to be very, very careful because this is in due process, and the protocols disappeared the next day. So we can't check any of those things. We just got an IE with very different results.
Yeah.
Is there anything to do? So she says, I looked in the hard cabinets, I checked my emails, I looked everywhere. They don't exist. It's a total mystery, violation.
I would say
of
that
conservation of matter.
failure to produce the protocols is a failure to establish the validity of the test.
Mm-hmm. We said that.
Well,
We lost.
hopefully
Yeah.
get the judge to say that. But that, yeah, if the protocols get lost, I would say that means the test is invalid because they have the burden. In an IE context, the school district has the burden to establish the validity and appropriateness of its testing. And testing without the protocols is not valid. Or you haven't established the validity. All right, errors in interpreting results. There's a tendency to minimize even the most obvious objective findings. I think in one of the case extracts, a CPS school speech pathologist administered a golden fristo and got a standard score of 40. And if you remember, standard score of 40 is like over 3 standard deviations.
6.6.
Huh?
Yeah.
So, and she wrote in a report there was a mild articulation disorder. I mean, that's kind of extreme, but those kinds of things happen, and again, you need that's extreme enough that it just stands up by itself. But some of them are a bit more subtle that you need a consulting speech pathologist to be able to say, yes, this description of severity and this recommendation for services is completely out of line with what the testing identified as an impairment. So I guess the other thing about private evaluations, some comments about selecting the person to do the IE. I always check for licensure. And that's the URL where you can go look it up for the State Department of Professional Licensing. And it applies to OT, psychologists, speech pathologists. And I can tell you that I didn't always do that, and bad things happen that made me start doing it all the time. I had there were actually two cases. There was one case where the psychologist had her license suspended for defaulting on a student loan. And it was reinstated, but not knowing that in advance, it caught me by surprise. And it was, you don't like surprises like that during a hearing. And luckily that ended up not affecting the credibility of that witness. But we've had a couple of cases where parents have retained private evaluators who ended up not being licensed, who were like working on getting the license, and would sign documents as though they were licensed. And so, always check. And by the same token, it's good to check the status of the school staff. You can look up the Type 73 status. That's the ISPE license for related service providers, to make sure that it is in fact current. There used to be a lot of paraprofessional speech pathologists around. They were usually people who got a BA degree and were working on a master's degree. And we found some of them that were there for like 10 years, when you're only supposed to be like a 2-year stint. But I haven't seen them around lately. Has anybody here come across the speech paraprofessionals? You have?
Yeah, she's filling in for a lead teacher.
She's what?
She's filling in for a lead teacher right now, but she was previously.
Well, I'd just be careful with them, because they will, in my experience, they end up doing things that only a fully licensed speech pathologist should be doing. All right, so in addition to licensing, some experience. I mean, Julie Demi is perfect because she's got a clinical practice. She works in the school. She works on IEPs. I mean, that's a great combination. Less good is somebody who has only a clinical practice. But if necessary, if that's all you got, that's what you have to go with. Willingness to do a classroom observation, I think, is important to establish that at the beginning of a relationship rather than spring it on them halfway through the evaluation. Also, a willingness to attend an IEP meeting if needed, and then a willingness to testify. I mean, there's a lot of evaluators don't mind doing evaluation, but they have a phobia about being a witness and being attacked on cross-examination. They just don't like it. And then payment arrangements. How's this person going to get paid? And is the client going to pay? Is the firm or the program going to pay? Or is it going to be for free? And one catch with the free ones is that you have to think about how it's going to be described, because I've had cases where they say, "We'll do it for free, and if you win, we'll send them a bill." Well, that's okay, but it also can create a risk of, the appearance that they're not only a hired gun, it's a contingent hired gun. All right, now, preparing testimony with the evaluator. I think it's important that they understand your theory of the case, what you're going after, and within that, they need to understand the difference between what's ideally beneficial for a kid and what's legally required. That is, and the context I always put it in is, if you were sitting in with an IEP team, what would you recommend as an IEP team member? Not as a clinician, what would be ideal for this kid to really help them? You know, so what would you recommend as a member of an IEP team? The basic procedures for the hearing will be there, particularly for somebody who's not testified before. The expertise of the hearing officer, there's a tremendous range from some hearing officers who really understand all this stuff about Steinheins and standard scores and percentiles, and there's some hearing officers who I think are pretty oblivious. So, you know, in some cases you may need to have that bell curve chart. I always use an outline. I prepare an outline for what I want to cover, send it to the evaluator, and spend an hour or two or more over the phone going over that. And then the elements of that typically include, you know, education, licensure, experience, the assessments that you did, who requested it, review, report elements, and then, you know, and then if usually if there's an IE issue, you need to also consider addressing the outside evaluators' review of school records, what specifically they found wrong, and then sometimes they may need to refer to the test manual. I've not gotten to the point of putting the test manual into evidence because sometimes they're pretty big. I've gotten away with simply having a person say, I administered this test hundreds of times. It comes with a test manual. I've reviewed the test manual, and this is what the test manual requires. And this protocol shows that it did not, whoever administered that did not follow the test, the manual for that test. What time are we supposed to be at wind up here?
10 minutes. 10 more minutes.
10 more minutes. Wow. I've got about another hour.
You have to come back.
Yeah. All right, well, here's some questions from the school district attorney. Who's paying for your testimony and how much? And it's kind of startling to somebody who's not experienced with this if they haven't been prepared to expect these kinds of questions and think about the answers, and you can discuss the answers, you know, how to respond. You know, how many times you've been a witness. I mean, I had one of our regular experts said, "Oh, I don't know, it's been a lot," you know. And afterwards, I said, "Wait a minute, you got to be a little more definite than that. You know, you got to try to be concrete." Who retained you is a key one because they always want to try and show that the lawyer is driving this thing, which is sometimes the case, but you don't need to help them make that point. Did anyone help you with administering the test? Which could often, if it's not reflected in the report, could be a major problem. And here's number 5 is another big one because your communications as a parent's counsel with the parent are privileged, but your communications with the evaluator are not privileged. And so they are entitled to ask the witness, you know, what did Mrs. Jones' lawyer tell you? And you should discuss how the witness is going to respond. Well, we went over the case, we went over my report, you know. The lawyer told me to be truthful and give short answers and, you know, that kind of stuff. I'll tell you another horror story that kind of reinforces, in my experience, the preparation for dealing with the question about communications with the parent counsel. It only happened once, but it's close. It was 10 years ago. The CPS attorney subpoenaed the emails between me and the evaluator. And to make things worse, the evaluator was doing a pro bono evaluation, had sent me an email asking me to write the introductory paragraph which explains the basis of referral. And I did. I just wrote this paragraph, said, you know, that the parent attorney made a referral for an evaluation based on questions concerning the school district's evaluation, and asked that the following areas be assessed. You know, it was pretty innocuous, but at the time it seemed like, oh my goodness, you know, this. The school attorney was trying to say that, you know, I was helping to write the report, and again, it worked. We survived that one, but it wasn't a pleasant experience. So be careful what you put in the emails with your evaluators, because there's always a potential that it can turn up. It's rare, but it could turn up in the school's hands, school attorney's hands. All right, you know, I guess I'm going to. I saved here for the end some tactical questions about pursuing IE that I've somewhat covered already, and that is almost every case. There's underlying, if it's a serious enough problem to be thinking about a due process hearing, there's some significant delays, significant inadequacy in services, some significant gaps in services, and generally underlying that are some very serious inadequacies in evaluations. And then the question is, how do you proceed? If the parent can get the evaluations done on their own, fine. And if they can't, well, what do? You can request the IE, but you can expect the school district to request a hearing, and then you're stuck with succeeding in winning that case by showing that the school district evaluations are inadequate. And in the first extract of Appendix C is a due process case where the kid, it's one of the most complex kids that I've ever represented. And we went into the hearing without any private evaluators, except for some medical staff, mental health and medical providers. And what saved us was that there was a suburban school district evaluation on speech, and there was some medical testimony, and there were so many things wrong with this, so many things that were wrong with the school's handling of this kid's needs, that the hearing officer just accepted everything we had to say. And I just suggest that you, at your leisure, look through Appendix C. But I put that in there really as a example of a lucky result. And also, that case was 10 years old, not 10 years, 5 years. It was in 2010. It's over 5 years old. The more effective approach, one way or another, is to arrange for a private evaluation to go when you request the IE. And then, what I would recommend, if at all feasible, would be to request the IE, get the private evaluation, file a due process request related to FAPE issues. They'll automatically be combined with the school district's IE due process hearing, and then proceed to a hearing where all that's combined. And it's also, not only is it useful in terms of challenging the school district's inadequate evaluations to have those outside evaluations, it also helps you in building your case about the failure to provide FAPE. And when all that's wrapped together, you're developing a very strong case to come out at the end with not only in order that the reimbursements be made for the evaluations, but there'd be a finding of FAPE violations, and you've got the outside evaluations with recommendations for services that you're going to ask the hearing officers to adopt. Because one of the problems with Exhibit C, or Appendix C, was that while we succeeded in getting an order that there be IEs, he didn't hold the case open to keep pending the the evaluations. He just said, fake denial, provide these services, outside evaluations, and then there'll be an IEP meeting to adopt the recommendations of the private evaluators. And the problem was that we got the IEs done, and the school district proceeded to ignore a lot of the IEs. And we ended up going to federal court and getting a preliminary injunction to order CPS to implement some of the IEs. And it turned out the case just became a serpentine thing that just seemed to never end. It went on for a couple of years. Although I am proud to say that this kid, who was in 4th grade at the time of the case, is now in high school at Coles and is doing okay. I mean, I can't say he's still got challenges, but he's in far better shape than he was when this case started. So I'm about out of time, I think. I guess I would just say, to the extent you have time, take a look at at these extracts related to an appendix C, D, and E. There's portions of the due process cases that deal with speech language and assistive technology. Letter to Fisher is OSEP. It's a Department of Education letter that establishes the legal obligations related to assistive technology to do evaluations, and also to get independent evaluations on assistive technology. And then Kevin T. is a case that's over 10 years old. It was an appeal of a due process case that established the standards. Well, it ruled that denial of assistive technology is a denial of fake, and it also has a good language on compensatory education services. Okay. All right, well.
Just a quick question regarding assistive technology or augmented communication evaluations. I know that in CPS, the delay to get those evaluations is so long. Has there been any kind of hearing decisions regarding that they have to comply with the 60 school day timeline for those evaluations?
Well, if they haven't complied, I guess it's I mean, the school code says
that's part of your, regular, it's an evaluation, so it has to comply with that. Because I feel like they don't get consent specifically for assistive technology or augmented
Well,
communication.
no, they should get consent. They should get consent.
I feel like we talked about the IP meeting and they put in like a order or something like that, and then like 6 months later.
Well, I'd say that's a violation. There should be, if there's a discussion on IP meeting that says, well, it looks like there may be a need for assistive technology, we'll request an evaluation.
Okay.
And then something gets lost and nothing happens.
It's not that it gets lost, it's that they don't have enough people doing those evaluations.
Well,
I was just gonna say, at least for Loyola, we, in one case, a parent came in with a recommendation for an assistive technology and augmentative communication evaluation that was checked on the IEP, and then it was never done, and it was pretty long at that time, it was like 11 months. But we filed an IE request for those specific evaluations, and then they filed for due process, and we were able to get the assistive technology and augmentative communications ordered on summary judgment, basically. So there was no hearing or no need, it was all done in motions, there was no need for a hearing, and we just got the IEs.
one in the back, Jennifer.
Michael, can you just comment for a minute on the fact that, at least within CPS, resources will drive the related services instead of the evaluation and the appropriateness. So what we're finding is that, some schools have better access to speech therapists who are coming in on a regular basis. Other schools don't have a speech therapist at all coming in on a regular basis. And then, surprise, surprise, the IEP, at the IEP meeting, if they don't have a speech therapist coming on a regular basis, they'll deny services altogether, or the school that does have a speech therapist will give the 15 or 30 minutes a week. So it's really resource driven, and I'd love to have some tips. I mean, obviously, I think we should be asking at the IEP meetings, do you have a speech therapist coming in? Who is that? How often do they come in? How much time do they spend here? To kind of get that out, if they're going to deny services or limit them to an inappropriate amount. But what are you doing that's different than that, or in addition to that?
No, well, I mean, we're just a little two-attorney firm. And actually, Jennifer, when I came in, Jennifer said, I thought you retired 2 years ago. No, I'm slowing down, so it's like 1.5, 1.25. I guess to the extent that you see a pattern and you can identify schools that don't have sufficient speech pathologists on a regular basis, I would say that's a basis for a complaint to ISBE. You know, they're required to investigate these things and respond. Or I guess another option would be a complaint to OCR. I mean, there's always the class action route, but that's very tricky in special ed. There's one that's been pending in upstate New York, in Attica, for about 5 or 6 years. But there was, I think, some extraordinary gaps in services to support that. There was a class action out of Milwaukee that went on for a while, and that Seventh Circuit blew that out of the water. So I think the only suggestion I have is to the extent that you can gather the data and put it into a complaint to ISB or OCR. And one of the frustrations from my standpoint is in the special ed practice is the limited opportunities for systemic advocacy. I mean, there's a lot of good individual work to be done, but either through administrative, legislative, or judicial class actions, there's very little opportunity to make anything happen. But that's just the way it is. But at any rate, one more. Okay.
I was going to ask, for compensatory services, or do you think, is there like a certain percentage to get it awarded? Or to ask for it? Why I say that is I noticed like in some of the West suburban school districts, like my own, you know, they don't start the services like speech and OT, things like that, even Wilson, if there's a Wilson course, until like a month after school starts. Then if you have snow days, or the OT or speech pathologist has a funeral, then you miss that day. And then you start adding it up, like I added up for one child recently, I'm like, wow, we're at like 22% of the time with all of this. You know, is that sufficient, or is there a formula or something that I should be doing when I'm looking at that?
No, I think if you're getting 22% of the special ed services called for in the IEP over a full semester.
A full year.
Not even a full year, a full semester.
Oh.
You know, I mean, why wait a full year? If this is happening, and you can document for a particular kid that they're supposed to get 60 minutes a week, and in 3 months' time, they only get, you know, 20% of that's whatever 60 minutes times 3 months times 4, 12 hours, whatever. You know, I'd say that's the basis to say that they're not providing the services in accordance with the IEP.
So, Michael, what do you think? Some school districts will front this issue, at least that's been my experience. Some school districts at the IEP meeting will say to me, well, instead of putting in 30 minutes per week, why don't we just put in, you know, whatever that comes out to, 120 minutes per month. And they'll say that way, if our therapist is out or she's sick or something, we can guarantee you that we'll still give it, but it just gives us some flexibility, and then we'll make sure they fit it in. And I kind of feel like, well, that sounds good to me, because you're guaranteeing to me that my kid's gonna get that. But is that a good practice?
I don't think so. Because I remember Julie Dem was saying, well, wait a minute, you know, periodicity is important, and reinforcement, and you know, if you get 90 minutes once a month instead of, you know, 30.
Well, if it's constant.
Yeah.
I was just trying to address the issue. I mean, people are gonna get sick,
Well, that's true, but if they make a reasonable effort to make it up.
And they
But
don't.
what I heard was that there were these gaps.
And they're not, no.
There was these gaps, and there was no effort to make it up.
Right.
And then,
No,
so then there's accumulation of gaps that ended up being a huge one.
The CPS's IEP actually says, like, will be provided monthly on it, and so, you know, I know that the idea is to do that, but then when you actually look at the service log, it's not being made up,
Right.
so I mean.
And that's the other thing,
Yeah.
it's not being made up, or even if they thought, what are they gonna do? They're gonna pull the kid. In the West, like our school district, they have bell-to-bell contracts for the teachers.
Of course.
They're not keeping him after school. I'm fine, give me the speech after, give him Ms. Wilson. They're not doing that. So that he's missing other things that he should be doing.
So
And
I-
that's part of the problem I see too.
So if over an extended period of time, a kid is getting less than half of the services called for his IEP, I think that's an issue.
Well, but you just said less than half. I mean, really, what's a good number? Is it 10%, 15%? I mean, is there something that you think is reasonable based on your, I mean, I don't know, based on
No,
your
I would,
experience?
I would partly look at what the kids'
Needs are?
needs are and how this seems to be affecting him.
Okay.
And he may be unhappy with the speech and not care whether it's being provided. I mean, I've seen those situations, you know.
Well, he prefers not to do his Wilson, but he needs it since he's reading 2 grade levels below, and you know, he prefers just to have gym all the time.
Well, I have a speech pathologist in the gym class.
And same thing with speech; they make him work. You know.
All right, well,
Thank you.
this
Thank
is
you,
a long
this is
afternoon,
great.
so thank you.
Yeah, he should work.
I have those daily certificates back here.
Well, that's a lot of
Come
social
get 'em.
things that,
Oh, and then if you just bring it and put it face down on my folder right here, the evaluation.